We are live now.
Good evening, delegates. I am Dr. Maunika. I welcome you all for today's CME, which is on TNFOG marathon on pregnancy-induced hypertension. I introduce Dr. T. Radhika Gauri ma'am. She is a specialist consultant in OBG and clinical lead, ISAC Hospital, Tirunelveli, Tamil Nadu. She has 10 years, and I introduced Dr. Sampath Kumari ma'am. She's a Foxy Vice President 2022. She's a professor and HOD, Sri Muthu Kumaran Medical College Hospital and RI. She's a Senate member, Tamil Nadu Dr. MGR Medical University, National Corresponding Editor, Journal OG of India, Founder Secretary, Tamil Nadu Federation.
Thank you, Dr. Monica.
I hand over the session to you, ma'am.
Thank you. Thank you. I welcome you all. Good evening. See, today we have our marathon CME.
What happened, Sampath? Your line got stuck.
Net போயிடுச்சு மேம் உங்களுக்கு.
நெட் இல்லாம போயிடுச்சுதான்.
Revati ma'am, you can start, ma'am.
Yeah.
You can start. Yeah.
I don't know whether she'll be able to come or not. Anyway, welcome all. It's really a great pleasure to welcome our chief guest, Dr. Meenambal, and also our Yuva speakers, Dr. Shamla and Dr. Prema Priya, and the judges for the same, Dr. Nitish Sharma and Vijay Lakshmi Kandasamy. And today we have got an important topic, especially a practical topic, PIH management. And next to PPH, now PIH is gaining importance now. And so everyone must know, not only the students, every practitioner must know in detail about this. And I also welcome my co-VP of Foxy, Dr. Sadhana Gupta, who is going to talk about preeclampsia solutions to challenges. And lastly, we have got a panel discussion for which Dr. Sampath is going to be the moderator. Always for Sampath, PIH is very close to her heart. Whenever this topic of PIH is being discussed either for a paramedical or for a CME or wherever it is, she said she will take up that topic. So to that extent, she is so much involved with the PIH topic. And we have got good number of esteemed panelists. I welcome all of the panelists, Sujata, Vanita, Tilenachar, Sai Meenakshi, Murugalakshmi, as well as Tendral. And I'm sure this is definitely going to benefit you all. And shall I introduce as chief guest? Can you show the
Tamil Thai Valtham?
Oh, yes. Okay, okay.
எத்திசையும் புகழ் வணங்க இருந்த பெரும் தமிழனே தமிழ
Hello,
Radhika?
Revati madam,
Yeah.
will you
Ah.
introduce our chief guest?
That is,
நடுப்புற என்னவோ கட் ஆயிடுது.
ஆமா,
So,
ஆமா, ஆமா. Okay, okay.
I invite our president, Dr. Revati madam, to introduce the chief guest to the delegates. Revati madam is our
Okay.
president of TNFOG. She was the past president of Madurai Society. She is the founder, president of Madurai Menopause chapter. And whatever happens in Madurai, madam will be the founder. Madam, that is the only simple word. Yes, madam, Revati madam.
Thank you, thank you. It's indeed a great pleasure for me to introduce Dr. Meenambal, our chief guest. She is my close friend, and she's a retired professor and HOD of Department of Madurai Medical, OG Department of Madurai Medical College. And she was in government service for more than 34 years. She was the past president of Madurai OG Society. And she was also professor emeritus of Tamil Nadu MGR Medical University. She is recipient of Lifetime Achievement Award from Tamil Nadu MGR Medical University. And in IMA, she is playing a lot of role. And she is doing a lot of work in women wing of IMA. And she was the first woman president of IMA Madurai branch 2013 and chairman women wing of IMA Madurai branch. And IMA women's wing is doing a lot of work for women's health. And she is doing commendable work on that. And she has conducted many CMEs as well as workshops. She has presented papers in ACOG as well as and Melaka, Manipal Medical College, Malaysia also. And she is, of course, a member of our Indian Menopause Society Madurai branch. Welcome, Dr. Meenambal, to say a few words and bless us. Kindly unmute.
Good evening. I am happy to be a part of the TNFOG. I thank the organizer, particularly Dr. Revati Janagiraman, who has invited me as a chief guest. The TNFOG is giving so many, giving us an identity to part of Tamil Nadu OBG society, and it spreads knowledge among the, and to dissipate knowledge among the undergraduates, postgraduates, junior, young OGCN and the senior OGCN also. Now the topic taken today is a very important, very common medical disorder. There are no single reliable test to identify or screen the gestation hypertension and the preeclampsia. When I have to tell you, it is a pregnancy specific multi-system disorder with the unpredictable variables. With the widespread manifestation, the cause remains still obscure. It is a major cause for the maternal, fetal, and neonatal morbidity and mortality. There are so many biophysical and also biochemical tests to assess and predict the PIH. Now there are so many speakers. They will be talking us on the pathophysiology, the classification of PIH. Let us listen to the speakers on the topic, because it's nowadays the PIH is becoming a nightmare for the obstetrician, because at any time it can go to any, it can cause many complications, unpredictable complications. Over to the speakers. Thank you, Revati and other organizers, for giving me a chance to come as a chief guest. Thank you.
Thank you, Dr. Meenambal. Welcome, Dr. Sadhana Gupta. Welcome. She's a presidential candidate for FOGC this year. I wish you all the best.
Thank you, Dr. Revati. Regards to Dr. Pandyan Binami, all the seniors, teachers, and thanks especially to Dr. Sampat Kumari for opportunity to be together. Thank you very much. Looking forward to great session.
Thank you. Radhika? Radhika, unmute yourself once. Next.
Radhika, are you there?
Good evening. Yes, ma'am.
Yeah.
Good evening, ma'am.
Yeah.
Sorry for the delay, ma'am.
Thank you, Dr. Meenambal, madam,
Sorry, ma'am.
for being the
Thank
chief guest.
Thank you, Sampat Kumari.
Thank you, madam.
Thank you, Sampath madam. Thank you, Revati madam. Sorry for the delay. Extremely sorry, madam. Now we will start with session 1, your session. Now I welcome Dr. Nidhi Sharma, who is a professor of obstetrics and gynecology at Savita University, and she is from Banaras Hindu University, Varanasi, India, and she's a fellow of Indian College of Obstetrics and Gynecology, and also is a fellow of assisted reproductive techniques. And she's done PhD in Obs and Gynae from Savita University, academic supervisor of fellowship in reproductive medicine and MSc in clinical embryology at Savita Medical College. And she has received Dr. Jagadishwari Mishra Prize for care of infertile in ACOG 2017. And she has authored several national and international publications and several chapters in textbooks. Welcome, Dr. Nidhi Sharma. And Dr. Vijay Lakshmi, who is a professor from Chettinad Hospital and Research Institute, Kelambakam, Chennai. And she has received special prizes and achievements during the State Secretary Appreciation Award for exemplary performance in IMA activities 2021. And she also has had important posts in OXY and other major bodies, past EC member in OXY, and she's also president of Velachery branch of IMA, chairperson of Women Doctors Wing IMA Velachery. Her special interests are high-risk obstetrics, adolescent gynecology, and gynae endoscopy. Over to you, madams.
Dr. Vijay Lakshmi can
Thank you.
introduce the first speaker. Yes, Dr. Vijay.
Dr. Nidhi Sharma, madam. Dr. Vijay Lakshmi, madam. Okay.
Sorry for I'm also on road and I just got cut. Can we have the first speaker, CE? Yeah. I would like to invite Dr. Shyamala Vignesh, who's a graduate from Chettinad. I'm proud to say that she is my student, and who has completed her MS OBGYN from Amrita Institute of Medical Sciences. And she's a consultant sonologist and obstetrician at Lakshmi Nursing Home, Valliyur at Tirunelveli district. She has several achievements. She's a gold medalist in the OG subject as well as in the anatomy and ENT during her undergraduate years, and has presented many papers, and she's even won a first prize for a paper presentation at the Malanadu OBGYN Society. And over to Dr. Shyamala for talking to us about the pathophysiology of PIH. The screen is yours, Shyamala. Let's go ahead. Dr. Shyamala, can you start sharing?
Yes. Can you see my screen, ma'am?
Not yet.
Not yet. Not yet.
Vijay, have you told her 12 minutes plus 3 minutes?
Yes. Shyamala, we have a deadline as regards your presentation. You'll have 12 minutes to present. That goes for the other speaker as well. And 3 minutes of discussion time. Please stick to your time limits.
Yes. Ma'am, I request you to
Dr. Nidhi here, ma'am. I have also joined, madam. Dr. Nidhi here, ma'am.
Welcome, Dr. Nidhi.
Welcome, Dr. Nidhi.
Yes,
I was wondering why you haven't joined yet.
Yes, ma'am. Yes, ma'am.
You can start.
Yes, ma'am. So good evening, one and all. I'm Dr. Shyamala from Foxy Tirunelveli, and I thank all the organizers for providing me this opportunity to speak. And without further delay, I shall start my presentation on hypertensive disorders of pregnancies, etiology. We all know the hypertension is the third leading cause for maternal mortality in obstetrics in India, whereas it is the number one cause for maternal mortality in developed countries. So coming to the classification, this will be further dealt by the next speaker. Just a gist of it, it is classified as gestational hypertension, preeclampsia syndrome, chronic hypertension, and preeclampsia superimposed on chronic hypertension. And it is no more as mild and severe, it is non-severe and severe. Gestational hypertension and preeclampsia syndrome can be subclassified as severe and non-severe. So what is important in the etiopathogenesis is the gestational age, that is, the early onset preeclampsia of less than 34 weeks has a different pathophysiology, whereas the late onset of 34 and plus weeks have a different pathophysiology. So coming to the topic proper, I'm here to assess the risk factors, the mechanism, and the organ-wise pathophysiology. So why do we need to assess the risk factor? While taking a good history from the patient, we can assess the risk factors of hypertensive disorders. And why do we need it? So that we can predict and prevent preeclampsia by adding aspirin to the high-risk mothers. So here are the non-modifiable factors, that is the age less than 18 or more than or equal to 35, Black women, low socioeconomic factors, and modifiable risk factors are the obesity, BMI of more than 30. And the most important here is that these are high-risk women are the first exposure to the chorionic villi, that is the primi gravida, the superabundant exposure of chorionic villi, as in hydatid mole and multiple pregnancies, a past history or a family history has a higher likelihood ratio of getting a preeclampsia, and ART conception and pre-existing maternal conditions leading to endothelial cell activation like diabetic, chronic hypertensive, renal diseases, autoimmune and connective tissue disorders. So the risk factors have been put forward by the NICE guidelines and the ACOG guidelines, where there are major and moderate risk factors, presence of one high risk factor or two moderate risk factors. We can supplement the woman with aspirin. Coming to the mechanism. So as told earlier, early preeclampsia and late preeclampsia have a different pathophysiology. Early onset preeclampsia, there is poor spiral artery remodeling, leading to poor placentation. But the late onset preeclampsia have normal spiral artery remodeling, and it is due to the senescence of the placenta that leads to preeclampsia in these late onset cases. Coming to the two-stage disorder theory, which is predominantly of early onset preeclampsia, the two stages are stage 1, the placental syndrome, and stage 2, the maternal syndrome. In the stage 1, there is the first factor is the abnormal placentation. The second factor being the immunological factor, third being the genetic factor. All these leads to placental hypoperfusion, leading to release of placental factors and endothelial cell dysfunction. So what happens in a normal placenta? There is interaction between the trophoblast and the decidua, leading to placentation, implantation. So what happens is that the trophoblast gets differentiated, the trophoblast, which is of paternal origin, gets differentiated into syncytial trophoblast and cytotrophoblast, which further differentiate into extravillous and villous trophoblast. The villous trophoblast are destined to form primary, secondary, and the tertiary villi, and the extravillous trophoblast play a major role in pathogenesis of preeclampsia. That is, they differentiate into interstitial trophoblast and endovascular trophoblast. The interstitial trophoblast, they migrate into the decidua and then into the myometrium, and they are responsible for immune system. They interact with the cells of the immune system. That is, they from the maternal side, they interact with the decidual NK cells, which I'll be telling on further. And the extravillous trophoblast, that is the interstitial trophoblast, migrate into the myometrium, forming and fuse and form giant cells, myometrial giant cells. And the endovascular trophoblast, they cause cellular plugging of the spiral arterioles, first at the endometrial level and then at the myometrial level. So this is called the first wave of trophoblastic invasion, which occurs by around 12 weeks, and the second wave of invasion, which occurs by 16 weeks. So finally, the resultant is that the spiral arteries are converted into a funnel-shaped vessel, thereby it is called the capacitance vessel, and there is a low resistance flow across this. So when the fetus has increased demands, the placenta has to give more blood. So this happens in a normal placenta. The substances regulating this invasion is the decidual NK cell. So there is an interaction between the NK cell of the decidua along with the interstitial cell of the trophoblast. How does it interact? By the presence of KIR receptor. So we can see that the NK cell has KIR receptor, that is the killer cell immunoglobulin-like receptor, and this gets attached to the HLA-C allele, HLA-C ligand present on the interstitial cell. So there is a normal immunological tolerance to the paternal antigen. So when there is an abnormal trophoblastic invasion, there is faulty endovascular remodeling. That is, the endometrial cells, the endometrial part of the decidua, that is the first part of the decidua gets converted into funnel shape, whereas the myometrial part remains as spiral arteries, which don't lose their elastic property. So this is classical of early onset preeclampsia. Coming to the immunological factors, as the intolerance to the the placental and the fetal antigen occurs in preeclampsia, which is similar to that of the acute graft rejection. When there is a paternal immune intolerance, as evidenced in complete molar pregnancy, where there is a increase in the paternal antigens, and when there is a fetal immune intolerance is evident by trisomy 13. So what happens is, in chromosome 13, we have the anti-angiogenic factor gene, that is SFLT gene is present on chromosome 13. When there is an extra copy of chromosome 13 in chromosome trisomy 13, there is development of preeclampsia. And the interstitial trophoblast express decreased amounts of immunosuppressive non-classical HLA-C. So all these, there is an immune maladaptation resulting in poor vascularization seen in preeclampsia. And the one more important factor is that in a normal pregnancy, the T helper cells, lymphocytes, are differentiated into Th2 and 1, and Th2 predominate in normal pregnancy. Whereas in preeclampsia, Th1 cells predominate. The Th1 is responsible for cytotoxic effect, whereas this Th2 is the safer one, that is the humoral immunity. So in preeclampsia, we have Th1 action. Coming to the genetic factors, we have preeclampsia appears to be a multifactorial polygenic disorder of which there are multiple genes associated with it. And this is evident as family history of preeclampsia. Daughters of preeclamptic mothers have high risk, sisters of preeclamptic women have high risk, and monozygotic twins have high risk. And these are the chromosomes that are responsible. 13 responsible for SFLT1 gene as seen in trisomy 13, and 12q resulting in HELP syndrome. And there is racial factors, that is African American women have lower incidence of preeclampsia. So all these leads to placental hypoperfusion. So a lower resistance flow, instead of a low resistance flow, we have high resistance flow across the uteroplacental bed resulting in ischemia. This ischemia releases the syncytiotrophoblastic debris and microparticles into the circulation, resulting in cytokine release and interleukins and TNF-alpha, resulting in oxidative stress and free radical damage. And there is also imbalance between the pro-angiogenic and the anti-angiogenic factors. The pro-angiogenic factors being VEGF and PLGF, and anti-angiogenic factors being SFLT1 and soluble endoglins. This results in imbalance in the prostacyclin and thromboxane A2 and decreased nitric oxide. So the SFLT1, it is an antagonist at the VEGF and PLGF, to VEGF and PLGF. This actually increases 5 weeks prior to the onset of hypertension in preeclampsia. Soluble endoglins, they attach themselves to the TGF-beta receptor, and they are increased markedly just before the onset of preeclampsia. These two results in anti-angiogenesis. And coming to the stage 2 syndrome or the maternal syndrome. So all these placental factors, cytokines, all these inflammatory changes results in endothelial cell activation in the mother. This oxidative stress provokes this endothelial cell activation. So this is actually called as systemic endotheliopathies, and it is the centerpiece for preeclampsia pathogenesis. In an intact endothelium of the mother, we have anticoagulant properties. It releases nitric oxide to keep it vasodilated and produces prostacyclin I2. And these two reduces the vascular response to angiotensin II. Whereas the opposite happens when there is an activated endothelium. So what happens? Damaged endothelium. So there is procoagulation resulting in platelet aggregation and thrombocytopenia. There is reduced nitric oxide resulting in vasoconstriction. And there is an increased pressor response to AT2 and norepinephrine. Also, there is an increase due to the damaged endothelium. There is increased vascular permeability, capillary permeability resulting in edema. So just a gist about nitric oxide, it is produced, it's a vasodilator by intact endothelium, and it has effect on the PLGF and endothelial growth factor. Endothelins are vasoconstrictors produced by the damaged endothelium. ET1 is the primary isoform in humans, and it is very much increased in hypertensive women than in normotensive pregnant women. And these are supposed to mediate the renal injury. So when we give Maxalt to the patient, it lowers the concentration of ET1. Prostaglandins, especially the prostacyclin produced by the endothelium, it blunts the response to AT2. And when there is a reduced production in preeclampsia, there is alteration in the PGI2 and thromboxane A2 produced by the platelet, and the ratio decreases. And in preeclampsia, there is increased sensitivity to AT2, resulting in vasoconstriction. These changes occur even as early as 22 weeks, even before the onset of hypertension. So finally, what we get is the endothelial activation resulting in INH, ischemia, necrosis, and hemorrhage. So when we come to the organ-wise pathology, we see ischemia resulting in perivascular infarcts, necrosis, fibrinoid necrosis of the arterial walls and brain, and cortical and subcortical petechial hemorrhages, which rarely reach to ICH as seen in non-pregnant state. Whereas the sudden increase in BP results in, it exceeds the normal cerebrovascular autoregulatory capacity, and there is loss of cerebral autoregulation resulting in hyperperfusion, and which leads to headache, which is a premonitory symptom in preeclampsia. And this hyperperfusion leads to perivascular edema and then convulsions. Stress is always seen in cases of eclampsia and 20% of severe preeclampsia. There is occipital lobe involvement resulting in, actually there is an increased capillary permeability and vasogenic edema of the occipital lobe resulting in blurring vision, diplopia, and blindness. The visual changes are presented even in 25% of severe PE and 50% with eclampsia. The classical lesions, we all know the Keith-Wagner classification of hypertensive retinopathy, where there is vasospasm in the grade 1 and grade 2, hemorrhage and soft exudates in the grade 3, and grade 4 with papilledema. Retinal detachment after a convulsion is very common, which results in temporary blindness and is reversible. The blindness, complete blindness, is very rare, and it is present in 15% of eclampsia. And occipital lobe blindness or amaurosis is reversible, and retinal infarction is a very rare entity resulting in Pershner's retinopathy. And cardiovascular changes. When there is a hypertension, there is increased peripheral resistance and increased load on the left ventricle, resulting in diastolic dysfunction. This may later progress as peripartum cardiomyopathy also, as they share the similar etiology. Increased capillary permeability and proteinuria results in third space losses. That is, there is an expanded extravascular compartment like edema, ascites, and all those, and a shrunken intravascular compartment. So in women with preeclampsia, when we give a vigorous fluid therapy due to any blood loss like abruption or blood loss, we need to keep in mind that they are at high risk for pulmonary edema and hypotension. The hepatic changes, periportal hemorrhages, vasospasm and edema results in stretching of Glisson's capsule, resulting in right upper quadrant pain. And hemorrhagic infarction around sinusoids result in subcapsular hematoma, and it rarely ruptures. There is transaminitis is very common in severe preeclampsia. However, the ALT AST levels are never more than 500, and they return to normal only after 3 days after delivery. So
We
hepatic.
have about 2 minutes, Shyamala. Sorry to interrupt.
Yes, ma'am.
Yeah.
The hepatic changes, the extensive hepatic changes are the HELP syndrome and the acute fatty liver of pregnancy. And the renal changes, the glomerular capillary endotheliosis is characteristic hallmark of in renal changes in preeclampsia. So there is a swelling of the endothelium of the glomeruli, thereby obstructing the capillaries of the glomeruli. So the glomerulus itself is enlarged and there is reduced blood flow going into it and there is reduced GFR. However, the tubular reabsorption part is maintained and there actually it is increased. So which conserves all the calcium, creatinine and uric acid, increasing those values on serum. And when there is a contracted intravascular volume, there is activation of renin-angiotensin system resulting in sodium retention. The most important is the proteinuria, which we can detect on urine analysis. AKI is very subtle in severe preeclampsia, that is only in 5%, and which increases with abruption and PPH. It normalizes to within 10 days after delivery. The hematological changes, the most common is the thrombocytopenia. And thrombocytopenia, it actually, the platelet levels fall even after delivery. So we need not be worried unless it goes or the patient exhibits more of bleeding. The endothelial activation and platelet adherence resulting in fibrin deposition and microangiopathic hemolysis, procoagulative state, there is increased chance for DIC. So, and the last, the uteroplacental changes because of the narrow spiral arterioles, low placental blood flow and placental hypoxia. These have the similar abnormal placentation can lead to gestational hypertension, preterm labor, FGR and abruption. So when we see the electron microscopic findings in placenta, the most important is the lipid accumulation in the myointimal cells, which forms atherosis. When there is acute placental atherosis, they are at higher risk of CAD later in life. So this sums up the pathophysiology. When there is a defective spiral artery remodeling, there is FGR, and when in the systemic release of placental factors and the cytokines, resulting in systemic vasoconstriction and endothelial dysfunction, and hypertension and end organ damage, especially the liver, brain, and the kidneys. So these are the take-home messages. Early onset, poor placentation. Late onset, normal spiral artery remodeling. So late onset is due to multiple interactions. One, because of the placental senescence, and second, the maternal genetic predisposition to cardiovascular and metabolic disease. This late onset preeclampsia is also grouped under metabolic syndrome nowadays. So that's it. Thank you, ma'am.
Thank you, Dr. Shyamala, for a very lucid and extensive presentation. Now you explained about what is the pathology behind when there is a change in paternity, there is an expression or a risk of increased preeclampsia, which we notice. What is the pathology behind that? Could you explain that? Am I audible?
Yes,
please
I'm
unmute
audible.
yourself. Yeah, please unmute yourself.
Yes. So when the presence of chorionic villi is the most important, when there is a change in the presence of chorionic villi as in primary paternity, these women are at increased risk because the immune tolerance is to the first partner and not to the subsequent partners.
So it's like she's exposed to the paternal antigens for the first time. Isn't it? Yes.
Okay, can I ask something?
Yeah, please, Dr. Nidhi.
Okay, how do you see? I have also gone through these things a lot, but still they say etiopathogenesis is unknown, isn't it?
Yes.
So if you have read so much, maybe more than me, were you able to figure out why it is more in teenage pregnancies? If you have
I have no explanation for it.
Yeah.
Age less than 18 is a risk factor.
Yeah. True, that is there, but we still don't know, no, isn't it? So pathogenesis is unknown. Okay, and another thing is there is lipid peroxidation. So one is free fatty acid overload. That is also, like you said, metabolic syndrome. That is. Okay, thank you. Nice presentation.
Can we now move on to the next presenter?
Yes, ma'am.
Dr. Nidhi will, Madam, please.
Yeah.
Yeah.
I welcome Dr. Priya. She is MS, DNB, MNMs, MRCOG from UK. She is Associate Professor at Vinayaka Mission Karpavaria Medical College at Salem, Tamil Nadu. She has numerous awards to her credit. She did the best poster and got the award from the Yuva Foxy South Zone Madurai 2016. She also got the Foxy Srimati Bhagwanti Devi Yamuna Singh Prize for the best paper in AICOG Bangalore. She also got Best Paper Award in TNFOG Annual Conference 2022. She has got a training fellowship in endogynec at GEM Hospital, Coimbatore. She has numerous publications, had done a lot of national and international presentations. She's interested in adolescent gynec and high-risk pregnancies. She's a master trainer at RAC Deva, and she's the executive council member of AGSOS. We welcome you, ma'am. We'll start with your presentation.
Thank you, ma'am. Thank you for your introduction, ma'am. Thank you for the organizers for giving this opportunity, ma'am. Is my screen visible, ma'am?
Yes,
Yeah,
ma'am.
visible.
Yes, it's visible.
Second. Today, my topic is classification on PIH. Hypertension is the most common medical problem encountered during pregnancy. PIH is the most common cause of both maternal and neonatal morbidity and mortalities. Globally, 10% of pregnancies are complicated by hypertension. 76,000 women and 5 lakh babies die each year from this disorder. The spectrum of this disease ranges from mildly elevated blood pressure with minimal significance to severe hypertension and multi-organ dysfunction. So, according to WHO latest report, the hypertension disorders contribute around 10 to 12% of maternal mortality worldwide. So, coming to the terminologies, earlier we used gestosis, then toxemia of pregnancy, PIH or pregnancy-induced hypertension. Now we are using the term hypertensive disorders of pregnancy to define the hypertension occurring during pregnancy. So, why this topic? What is significant? It is always essential to categorize the correct definitions based on the disorder so as to appropriately manage and prevent the fetal-maternal complications. So, our mind is so tuned that edema, proteinuria, and hypertension is preeclampsia according to the gestosis. And previously, we have divided the preeclampsia into mild, moderate, severe, depending upon the severity of hypertension and amount of proteinuria. But this classification is outdated. So, what's new? So, the present classification of hypertensive disorders of pregnancy has been derived from various international organizations such as ACOG, NICE, SOGC, International Society for Study of Hypertension in Pregnancy, National High Blood Pressure Education Program, and the Foxy Gestosis ICOG 2019 has given us the good clinical recommendations to define hypertensive disorders of pregnancy. According to International Society for Study of Hypertension in Pregnancy, the hypertensive disorders are classified as gestational hypertension, preeclampsia, eclampsia, chronic hypertension, superimposed preeclampsia on chronic hypertension. According to ACOG 2019, it is also the same, and preeclampsia is divided into non-severe and severe. With Foxy Gestosis Good Clinical Practice Recommendation 2019, the hypertensive disorders of pregnancy are classified as gestational hypertension, chronic hypertension, preeclampsia, eclampsia, superimposed preeclampsia on chronic hypertension. The preeclampsia is again divided into non-severe, severe, early onset, late onset, preterm, and term preeclampsia. So overall, the hypertensive disorders of pregnancy can be categorized with less than 20 weeks or more than or equal to 20 weeks. If it is less than 20 weeks, that is chronic hypertension. If it is more than or equal to 20 weeks, it could be a gestational hypertension, preeclampsia or eclampsia, or chronic hypertension superimposed preeclampsia. So moving to the first entity, that is gestational hypertension. It is the most common form of hypertension. So here the blood pressure is more than or equal to 140/90 mmHg, which is found in more than 20 weeks of gestation on 2 occasions at least 4 hours apart in a previously normotensive woman, and it returns to normal within 12 weeks postpartum. It is not associated with any feature of preeclampsia. If the blood pressure is more than or equal to 160/110 mmHg and not associated with preeclampsia, it can be called as severe gestational hypertension. In severe hypertension, the diagnosis needs to be confirmed within the shorter intervals. We need not wait for 4 to 6 hours to confirm. It should be confirmed within minutes so as to facilitate the antihypertensive therapy. Chronic hypertension. It is a known case of hypertension either before pregnancy or before 20 weeks or doesn't return to normal within 12 weeks postpartum in the case of gestational hypertension. And this chronic hypertension could be essential primary hypertension or secondary hypertension due to some underlying disorders such as renal vascular disease or endocrine diseases or even thyroid. Coming to the preeclampsia. It is a multi-system inflammatory disease which occurs beyond 20 weeks of pregnancy. It is characterized by hypertension, that is blood pressure more than or equal to 140/90 mmHg on 2 occasions at least 4 hours apart, or blood pressure more than or equal to 160/110 mmHg, which is reconfirmed within minutes in a previously normotensive woman with significant proteinuria. Here the proteinuria is 300 milligram or more of protein urine excretion in a 24-hour urine collection, or it could be spot protein creatine ratio of 0.3 milligram per deciliter or more, or if the quantity methods are not available, then urine dipstick test of 2+ or more is considered as proteinuria. According to the ACOG guidelines of 2019, even in the absence of proteinuria, new onset hypertension with new onset of any of these following. It could be a thrombocytopenia where the platelet is less than 1 lakh, renal insufficiency, that is serum creatinine more than 1.1 milligram per deciliter, or doubling of serum creatinine in the absence of other renal disease, impact liver function, that is elevated blood concentrations of liver transaminase more than twice the normal concentration, pulmonary edema, new onset headache, which is not settled with any medication or not attributed to other causes, visual disturbances, or fetal growth restriction. These hypertension, that is more than 160/110 mmHg, severe hypertension, thrombocytopenia, renal insufficiencies, impaired liver function, pulmonary edema, new onset headache, visual disturbances, or classified as severe features and severe preeclampsia. Health syndrome, as we all know, hemolysis, elevated liver enzyme, low platelets. This also comes under severe preeclampsia. According to the International Society of Study of Hypertension Pregnancy 2021, gestational hypertension of occurring in at or more than 20 weeks, accompanied by one or more of the following new onset conditions such as proteinuria, other maternal organ dysfunction such as kidney injury, liver involvement, neurological complications such as altered mental status, blindness, stroke, severe headache, visual scotomas, hematological complications such as thrombocytopenia with the platelets less than 1.5 lakh, DIC, coagulation disorders, hemolysis. All these comes under maternal organ dysfunction. Uteroplacental dysfunction could be due to fetal growth restriction, abnormal umbilical artery Doppler waveform, or stillbirth. The preeclampsia, according to FOG ICOG guidelines, can be divided into. Ma'am, am I audible, ma'am?
Yes, you're audible. Kindly, all others, please mute yourselves. Thank you.
Preeclampsia could be divided into non-severe and severe. In non-severe preeclampsia, the blood pressure is more than or equal to 140/90 mmHg and less than or equal to 160/mmHg with no premonitory symptoms and normal hypertensive disorder pregnancy lab parameters. The premonitory symptoms include headache, blurring of vision, vomiting, right upper quadrant pain, sudden excessive weight gain, more than 5 pounds weight gain in a week, or severe edema. In hypertensive disorder pregnancy lab parameters, it includes low platelets, elevated liver enzymes, elevated serum creatinine, or abnormal coagulation profile. In severe preeclampsia, either blood pressure more than 160/110 mmHg with or without premonitory symptoms or abnormal lab parameters, or blood pressure more than or equal to 140/90 mmHg with premonitory symptoms or and abnormal hypertensive disorder pregnancy lab parameters. So, most of the times, typically preeclampsia occurs more than 20 weeks. but there is an entity that is atypical preeclampsia, which can occur even before 20 weeks of gestation or even after 2 days postpartum delivery. So it can be associated with other causes such as antiphospholipid syndrome, lupus nephritis, or molar pregnancy. So coming to the preeclampsia, based on the onset of proteinuric hypertension, if it is less than 24 weeks, it is early onset preeclampsia. If it is more than 34 weeks, it is late onset preeclampsia. Early onset preeclampsia, the maternal complications are more severe, whereas in fetal complications also more severe, such as low birth weight, fetal growth restrictions, and iatrogenic prematurity. In late onset, maternal complications are less severe and fetal complications are less common. Coming to the eclampsia, it is a new onset tonic-clonic focal or multifocal seizures in the absence of other causative conditions, such as there should not be any epilepsy or cerebral artery ischemia, infarction, or hemorrhage or drug use. It could be in antepartum, intrapartum, postpartum eclampsia. So the next entity is superimposed preeclampsia on chronic hypertension. It is occurrence of preeclampsia in a woman with known case of chronic hypertension. That is, in the absence of pre-existing proteinuria, new onset proteinuria with a setting of rise in blood pressure is sufficient to diagnose superimposed preeclampsia. Women with chronic essential hypertension developing any of the maternal organ dysfunction consistent with preeclampsia, also labeled as superimposed preeclampsia on chronic hypertension. So overall, the blood pressure measurement is very vital in hypertension disorder management. So for the appropriate technique is the patient must be seated, seat supported, rest for at least 2 to 3 minutes before blood pressure is measured. Left-sided positions preferred in the bed-bound mother. First, systolic blood pressure should be taken by palpatory method, and then it should be confirmed by oscillatory method with Korsakoff space count 1. And diastolic pressure is recorded at Korsakoff space 5. A standard cuff can be used if the arm circumference of the woman is less than or equal to 33 centimeter, and largest cuff should be used if it is more than 33 centimeter. So always remember that mercury thermometer is a gold standard for blood pressure measurement. So we have seen most of the classification of hypertensive disorders of pregnancy. So here are some of the fascinating terms. So let's have a quick look of these. That is transient hypertension. That is the blood pressure of more than or 140/90 mmHg, which is recorded and it is not confirmed at rest or repeat measurement. Only one recording is there and it settles off as such without any treatment. That is transient hypertension. So it could be due to either environmental stimuli or stress of labor, etc. Resistant hypertension, that is blood pressure not controlled with 3 antibiotic drugs in appropriate doses for more than 3 days. That is resistant hypertension. Delta hypertension, this mean arterial pressure suddenly rises but still in normal range. That is delta hypertension. It is more prone to develop preeclampsia. The other is unclassified hypertension, when it does not fit into any category and we are not sure whether she is that normotensive or not before the measurement of blood pressure during pregnancy, then we can classify as unclassified. There are other terminologies such as white coat hypertension, where the blood pressure is raised more than or equal to 140/90 mmHg during the office or clinic hours, but it is normal at home or work. And masked hypertension is blood pressure is normal at clinic but elevated at other times. So these can be diagnosed by 24-hour ambulatory blood pressure monitoring or automated home blood pressure monitoring, because these can be at risk of preeclampsia. There are other two entities such as hypertensive urgency and emergency. Severe asymptomatic hypertension with blood pressure of systolic more than 180 and diastolic more than 120 mmHg is called as hypertensive urgency. Whereas hypertensive urgency accompanied by end organ damage such as cardiac, neural, or renal will be called as hypertensive emergency. So coming to the summary, pregnancy-induced hypertension or hypertensive disorders of pregnancy can be classified into gestational hypertension, preeclampsia, eclampsia, chronic hypertension, and superimposed preeclampsia on chronic hypertension. The diagnosis of preeclampsia is made when hypertension is present with maternal organ dysfunction or uteroplacental insufficiency, even if there is no proteinuria. Classification of severity of preeclampsia in terms of amount of urine protein excretion is abolished. Mild preeclampsia term is no longer used. So preeclampsia can be either non-severe or severe. Presence of severe features, severe hypertension with predominantly symptoms, or hypertensive disorder pregnancy abnormal lab parameters indicate severe preeclampsia. Early onset preeclampsia is less than 34 weeks and late onset preeclampsia is more than 34 weeks. So coming to the conclusion, at this juncture, I want to convey that let's all take as an opportunity to screen for non-communicable diseases so that we screen for the hypertension non-competitive disease even before they're pregnant. And if a pregnant woman comes, we should measure blood pressure at each ANC visit. And if elevated, we have to classify the type, whether it is less than 20 weeks or more than 20 weeks. Assess the severity by doing investigations such as proteinuria, complete blood count, renal function test, liver function test, peripheral smear, optic fundus examination. Correct the hypertension with antihypertensive drugs. Monitor the maternal and fetal well-being. Give a strict vigilance. If there is any worsening symptoms, then plan the appropriate timing and mode of delivery. With proper treatment and prompt treatment, we can reduce the maternal and fetal complications. So I would like to end this topic with the famous quote, "The eye sees only what the mind is prepared to comprehend. Early prediction and early detection saves life." Let us all work together to prevent the preventable hypertensive disorders of pregnancy. I thank the TNFOG and my Salem Obstetric Gynecology Society President and Secretary for giving this opportunity to present in this prestigious forum. Thank you, ma'am. Thank you all. And these are my references.
Okay, thank you, ma'am. It was a very beautiful and elaborate presentation. I have one question for you.
Yes,
Which eclampsia is most dangerous? Antepartum, intrapartum, or postpartum eclampsia?
Postpartum eclampsia is dangerous, ma'am.
Yeah. Can you tell? That is correct answer. Postpartum eclampsia is more dangerous. Why?
If you deliver, then the placental pathology is out, ma'am. So, but after the placental pathology is removed, still the eclampsia occurs. It can lead to other complications like a cerebrovascular accident or Press syndrome, like that it can go, ma'am. So it is very dangerous.
Yeah, because basically, even after the delivery of placenta, if the patient is convulsing, that means it is because of in the postpartum period, there is something called diuresis. So that happens under the influence of atrial natriuretic peptide, which is secreted from the myocardium. So if the patient has been normal throughout and she's not undergoing postpartum diuresis, that means that shift from the compartments is not going on. That means her intravascular volume is still high and she can throw a fit. So that postpartum eclampsia is not related to placental pathology and it is the most dangerous thing. That is correct answer. Thank you. Ma'am.
Nice presentation, Prema.
Thank you, ma'am.
See, if you have a patient who probably has one reading of say 130 by 85, and is the older classification of elevation of the blood pressure from the earlier values of more than 10 millimeters from the pre-pregnancy diastolic and 30 from the systolic still hold good in the classification and in the management at least? What is your take on that?
Ma'am, but we have to have a close look on that patient, ma'am. If it's crossing more than 140, but according to the present classifications and the guidelines, ma'am, more than 140/90, we have to treat her, ma'am. But we have to have a close look on that.
What is your take on the mean arterial pressures and putting that into our classification system? The role of assessing the mean arterial pressures?
Yes,
currently, what is our
it should be less than 100,
role
ma'am.
of MAP? Yeah.
It should be less than 100, ma'am.
Yeah.
Because of the justice score, ma'am, we can predict the preeclampsia, ma'am. If she is at high risk, then we can give her the aspirin or calcium supplementation so that we can prevent preeclampsia. So if she's under 130/85 borderline, we can give her a aspirin or calcium so that she can get benefit, ma'am.
Do you think supplementation of aspirin to these women with your risk assessment at the 11 to 13 weeks prevents preeclampsia 100%?
Benefit outweighs the risk, ma'am. So
we cannot prevent preeclampsia. We can only prevent the complications of preeclampsia.
You can only prevent complications. But haven't you seen in your practice that in spite of giving them aspirin, these women do develop preeclampsia?
Yes, ma'am.
Isn't it? Yeah.
Yes, ma'am.
Yeah. Thank you, Dr. Priya.
Thank you, ma'am. Thank you so much, ma'am.
Yeah.
Sahiti, can you post the question?
Yes, ma'am. Yes, ma'am. First question, only one question. Can you see?
Gestational hypertension is defined as an increase in BP more than 140/90 without proteinuria, increase in BP 140/90 with question is wrong. Sahiti, second is with proteinuria. Both you have written as without proteinuria. Radhika.
Ma'am, just now.
Sahiti, you change the question. Increase in BP first is without proteinuria, B is with proteinuria. Increase in BP less than 30 weeks, D is none of the above. Change and post it.
Second question is.
Question is there, ma'am, or else shall we post that?
Or else we can post this after Sadhana madam's talk.
Okay, ma'am.
Okay. Madam Sadhana madam, welcome you. Dr.
Thank you,
Revati
thank
madam.
you. Thank you. Regards to all seniors.
So madam is a candidate for presidential post to Foxy 2023 election. Can you post a CV? Revati madam, are you there?
Yes, ma'am. I'm
Yes,
sharing.
Madam, would you introduce Dr. Sadhana Gupta madam?
Yes. Please show the CV.
Ma'am,
Revati
chairperson.
ma'am, Manonmani madam. Madam, Manonmani madam is there.
Manonmani is there. She's the chairperson.
Sorry, Manonmani madam irukangana.
Mano, you introduce Mano.
Yes, Manonmani.
Yeah.
Revati ma'am, you introduce Manonmani madam, please.
இல்ல நானே introduce பண்ணிடுறேன் ஒன்னும் பிரச்சனை இல்ல ரேவதி மேடம்
Manonmani introduce பண்ணிடு
Dr. Manonmani, who is the chairperson for Sadhana Gupta madam's talk. She is the professor and HOD of Coimbatore Medical College, Tamil Nadu Government Service since 26 years and UG/PG teacher for 17 years, present president of Coimbatore Society, and she has many publications, more than 20 original papers, and co-chairperson of UA Foxy South Zone and Cox Managing Committee member, District MTP Committee, and Chief District Obstetrician. She has got award from collector also. Madam Manonmani madam, please introduce Dr. Sadhana Gupta madam.
Good evening all. Thank you Sampath madam for those kind introduction words, and I thank TNFOG and Revati ma'am and our team members for giving me this opportunity to introduce none other than Dr. Sadhana Gupta. I welcome ma'am for this wonderful talk by you in the preeclampsia topic. Actually, she is a co-chair SFOG NCD committee and Foxy representative FACOG 2018-21, vice president Foxy 2016. She had been ICOG governing council member with the best governing council award in 2021, corresponding nation editor and peer reviewer for Jogi. She is a Foxy past chairperson for the Safe Motherhood Committee, and thrice country representation to WHO on key women health issues on quality RCH and essential postnatal newborn care and MDG. 3 times she has won Korean Award, 4 times AACOG research papers, and she is sole author of the book Cesarean Delivery, Vaginal Delivery, and a comprehensive textbook of ONG by JP Publications, editor of Safe Motherhood Bulletin, ICOG Campus and Foxy Focus, and a book on Safe Motherhood Initiative, and Silent Revolution. She is awardee for 3 times Dr. DC Datta Prize for the best Foxy publication and manual, awardee of chancellors, and Dr. Naval Kishore Gold Medal for best MBBS and postgraduate student, key organizer of national international conferences in Saving Mothers 2016-19, Abhiyan Foxy Figo, SFOG 2021, Prevention of Stillbirth in 2021. She had been honored at National International Forum for exemplary work done to reduce maternal mortality, community service, and women empowerment, namely Padma Bhushan, Kamalabai Hospital Award, Dr. R. Malhotra Award, Dr. Durusha Award for Distinguished Community Services, recipient of Dr. N.A. Shagita Pandit Award for Women Empowerment 2021, Economic Times Award for Services in COVID Times 2021, Director and Senior Consultant of OB-GYN, Jeevan Jyoti Hospital and Medical Research Center, Gorakhpur. Apart from that, she is a Foxy presidential candidate for the election year 2023. Welcome you, ma'am, for the talk on PIH solutions and challenges. So you have been hearing so far how dreadful it is. More than 1/3 of the maternal mortality because of this preventable disease. So we welcome to enlighten us on the solutions and challenges. Screen is yours.
Thank you, Dr. Manuri, for kind introduction. My regards and thanks to Dr. Sampath Kumari, Dr. Revati, our chief guest, Dr. Peenambal, and all the dignitaries and the faculties, and a wonderful talk. Congratulations to all young who have done a great job in setting the stage for my talk. So the preeclampsia, what are the emerging concepts and few solutions to challenges. So we know so much and still we don't know few things why the teenage have the preeclampsia, and that is the thing what is all about science. So it is about me, and I seek everybody's blessings, guidance, and support for my Foxy presidential candidate. And thank you always for staying together. So we had a so close relationship. Dr. Revati was my co-vice president, and we had wonderful relation. We all had the energy and the dedication of Dr. Sampath, and like how we carry on that legacy of simplicity and the dedication in Foxy. So this is a real a journey which was worth traveling, and we learned, shared a lot. And I've been greetings from land of Buddha, and we can never obtain peace in the outer world until we make peace with ourselves. So it is all about our profession that we have to be with peace with ourselves. So we are together to save lives, and always what the young generation, what TNFOG, Dr. Sampath, you have that great legacy that you have the youngsters at the first beginner of the academic session, because we have to be somebody's strength, be someone's inspiration, and be someone's reason to never give up. So preeclampsia is a mystic and mysterious. So all have said, like God, it has got many names because we cannot understand why there is a preeclampsia or hypertensive disorder. But the beautiful observation, right? When the technology was not available, even then we had the good observation of human mind that somehow it is related to chorionic villi. It has to be removed if we want to treat the mother, and sometimes it will not be so great that the pregnancy need termination. So a good statement clinical. We all know that it is contributing to a lot of not only the maternal criticality and the maternal mortality, but also a lot of the fetal and the perinatal morbidity and mortality. So it is contributing. At some places, it is the #1 cause for the direct maternal death. And preeclampsia, that is one classification of the hypertensive disorder, is going to affect around 3 to 5% of pregnancy. In India, still today, when we are having the third largest economy of the world, we are losing around 35,000 mothers per year due to the hypertensive disorder in the pregnancy. The thing does not end there, because it is not only the short-term criticality, short-term mortality, but a long-term effect on the mother, because mother is going to have more prone to the metabolic disorder, and the babies born to the preeclamptic mother, they also have the higher risk of having all metabolic disorder. So in India and South Asia, when we are really struggling with the non-communicable disease, obstetrician intervention is going to do a lot in preventing the tsunami of non-communicable disease in our country, because our intervention is going to help the next generation health also. So it is how we define. So Shyamla and the Shyamla and the Prema have said that it is the blood pressure which is more than 140/90, but it seems very easy because it has to be measured in a sitting or left lateral position after 20 weeks, good appropriate size cuff and the calibrated sphygmomanometer. So it sounds simple and easy, but it is nothing is simple in complex one when we are having 40, 50, 100 patient right in the queue, and we have to be very, very careful that the blood pressure is taken in the right way. Now we are not having mercury sphygmomanometer because of some environmental issues. So it is again the ground root responsibility that our aneroid or the automated electronic blood pressure machine has to be calibrated against 1 or 2 mercury sphygmomanometer, and that has to be cross-checked. So it is a ground level issue and we have to deal it. all white coat mask delta hypertension. Just one message I want to give, that even a white coat hypertension, even a delta hypertension, when we have, it is not normal, because these patients who have the occasional reading of hypertension, they are more prone to develop the hypertensive disorder as well as the preeclampsia. So this is important, that these patients who have the occasional reading need to have a close follow-up. So correct assessment of blood pressure is very, very essential. So always take twice blood pressure. This is like my OPD routine, that once there is, I say it is blood pressure, I always say any symptom, anything, that recheck the blood pressure. And if the 2 readings are okay, then you can omit 3 reading. Otherwise, you have to make 2 or 3 readings. So it is not a one-time reading. Early onset and late onset, our all youngest speaker have talked about it, but the early onset preeclampsia is considered a fetal disorder. Just a good understanding that causes placental dysfunction, fetal growth restriction, abnormal umbilical artery Doppler. But the late onset hypertension is a considered preeclampsia maternal disorder due to the underlying constitutional factor, and we have a good prognosis with the late onset. So it is all about classification. Everything has been said and done. About proteinuria, I will just put a few points where the people are getting confused. So for a long time, when we have the senior, it is a triad of hypertension, proteinuria, and edema. So over the last 10 years, it is that the proteinuria is not mandatory for the diagnosis. So I want to highlight that it is not mandatory, but proteinuria is a very, very important step in the diagnostic modality. And simple depistic test, that is around 2+ or the 3+, is the simplest test when we can do in OPD, in emergency, day and night. And we have to take. So absence of proteinuria is not the absence of preeclampsia, but the presence of proteinuria still is an important diagnostic tool. 24-hour urine was always an impractical thing, and we have to believe on our urine depistic tests, which are easily available. Any nurse, any person can do it, and around 2+ is the discriminatory value. So this is the simple tool which we have to tell. Second thing is that it is a hypertension, it is a proteinuria, and any organ dysfunction. So it is and or. So proteinuria is there, it has not gone, but even if it is absent, but we are having the altered liver or kidney dysfunction or the platelet count or any neurological sign, this is also called preeclampsia. Classification has been covered, and I will just like to emphasize a little bit repeatedly that for practical purpose, it is a recommendation that we ought not too much emphasize on the severe and non-severe classification, because any time patient can go from the severe, non-severe to severe. So every patient with preeclampsia need that close monitoring. And it is like a fire which is spreading right from the brain to the leg. And in all the patients, I really always counsel that it is like a fire. It is going to affect your every organ, and we have to be very, very careful. So all etiopathogenesis, 1 or 2 things I will add, that it is a acute arthrosis, which is again considered a newer form of etiology, that the multiple form of vascular inflammation stimulate acute arthrosis, which cause the remodeling and the preeclampsia. First and second stage are okay, but in the body, it is not any first or second stage. In the body, it is going simultaneously. So such staging is artificial, like we know for teaching, discussion, discourse, understanding, but preeclampsia syndrome presents clinically as a spectrum of worsening disease. So we have to be very, very careful. Few interesting points to ponder, like what we say, we don't understand, then it is become something classic. So fetus is not requisite for the preeclampsia. Molar pregnancy can have preeclampsia. They can be extra-abdominal, so even ectopic and the abdominal pregnancy can have preeclampsia, genetic, epigenetic, a lot of both. And what the Shyamla says, that the fetal gene also control the susceptibility to preeclampsia. So this is something, and this is a lot of like a what cause it is capillary leak, it is oligohydramnios, fetal growth restriction. So fetal growth restriction with oligohydramnios is considered a form of preeclampsia even in absence of high blood pressure. So this is very important, and this what I say is that the placenta and preeclampsia, this is a new understanding in the preeclampsia, that the suboptimal cardiovascular performance is the cause of the abnormal placentation. So placenta is not a villain, but it is a victim, because the woman is not having a good cardiovascular adaptation to pregnancy. That's why it causes the abnormal trophoblastic invasion and subsequently preeclampsia. That's why when we are having twin, when there is a more overload of the chorionic and the heart need to work more, then we have the preeclampsia. After first pregnancy, patient is less prone to develop preeclampsia, but after 5 years, it becomes the same. So it is a very good, and like it is going to change our understanding to the preeclampsia. A little bit about prediction and prevention. So we all inverted pyramid of antenatal care. But I want to say that in every setting, we can do prediction. So it is not so that we always have to have a good, very, very good ultrasound machine and the ultrasonologist, but just measurement of maternal clinical factor and a good measurement of blood pressure can detect around 80%, predict the 80% of the preeclamptic women, especially the early onset, not if not the late onset. So the best screening test is the maternal risk factor, mean arterial pressure, and then comes to the biomarker and the uterine artery pulsatile index. And if we are doing the genetic aneuploidy test, then the low level of PAPA. Gestosis Indian chapter score is great because it is clinical. Everybody can use it. And if it is more than 3 or above 3, we can use the preventive measure. So I say everybody is aware of gestosis score now, and we have to use in our clinical factor. Biomarkers, so low level of PAPA, PLGF level is low, and SFLT, ratio of the SFLT and the PGL. So one point I will like to say, it is important that it is workable. It predicts the preeclampsia even in second trimester. But the important thing is that it predicts that this patient is going to have preeclampsia or not going to have in next 7 to 10 days. So this test is very, very important place if we want to refer. Patient is in a rural sector. She is in a community health center. And if we have this test and we want to refer the patient in right time, then this is a very, very good test. So SFLT PLGF ratio is a valuable because it is workable in the second trimester. If it is value of 38 or lower, it can predict that this patient is not going to have adverse obstacle outcome within 1 week, and you have to repeat it sometimes. So if you are doing tests, but we are doing nothing, or already the patient is in a very, very good community health, like a hospital setting, then you can use or you can consider how to use this test. But we have to know that SFLT PLGF ratio has come as a good predictive test for the adverse obstacle outcome in next 7 to 10 days. So it is all, and I emphasize that the good clinical history and a good mean arterial pressure does a lot. And when you have a high risk factor, you can go for the uterine artery Doppler studies and the other biomarker. This is FMF calculator. Our young generation is very much like tech savvy, so you can put the value and you can calculate the real risk. So sometimes we we can use it in our clinical practice. What given home? So it is aspirin. What is the ASPIRE trial? 150 milligram daily for 11 to 40 week till 36 to 37 week, and the calcium supplementation. So important thing is that the Doppler study, even the FIGO says that in low resource setting, the two things work, that is the prediction, this clinical factor and the good measurement of mean arterial pressure. And whenever it is feasible, the uterine artery Doppler we can do. So what we have, aspirin and the low calcium supplementation, where there is the low calcium intake. So these two things we can have as a preventive measure. And what Dr. Nidhi and the judge was saying, that sometimes we are not able to prevent at all, but it may prevent the severity of preeclampsia as well. So it starts before around 11 to 12 week until 36 week. It is a dose dependent, and the calcium supplementation in Indian women, we can say we are giving anyway to everyone. So do we recommend aspirin to all women? No. So this is a answer, because we are writing really aspirin right and left for every problem. So we have to say what are the high risk and the moderate risk. These women need to give the this aspirin supplementation. So again, I emphasize that the severity between the severe and the differentiation between the severe and non-severe can be very, very hazy. It is all proteinuria, thrombocytopenia, renal insufficiency, liver involvement, and the cerebral system which cause the severe, which comes into the category of the severe preeclampsia. And important thing is why we want to are so much concerned about the preeclampsia, because when there is a severe preeclampsia, we can have the life-threatening complication like pulmonary edema, infarction, stroke, ARDS, coagulopathy, renal failure, IUFD. So it is like a fire, it is affecting the woman's body, and there can be the rapid deterioration of maternal and fetal status. So short and long-term perinatal, what I say, it is not only affecting mother, it is highly affecting the fetus. We can have a short-term IUGR, oligo, IUFD, but also the long-term complication like cerebral palsy, hearing loss, visual impairment, insulin resistance, diabetes mellitus, coronary artery disease, and hypertension in the future next generation, the baby is born to the preeclamptic mother. So again, say important thing in clinical setting, because when we consider our science, we consider every woman. We want to save mothers everywhere. So every patient who is having high, more than 140/90 blood pressure, or she is having proteinuria, or she is having any deranged organ function, might make it that these all patients need as close observation as a patient with the severe preeclampsia, because we don't know that at what moment patient is going to from non-severe to the severe. So it is ISSP recommendation that every woman need very, very close observation. What we want to achieve in our management, we want to terminate the pregnancy when mother is healthy and the baby is healthy. And after delivery, the health of mother is completely restored. Most of these objectives can be accomplished if we terminate the baby terminate the delivery at right time, and we prevent the life-threatening complication. So this is important when to start the blood pressure. So like our judge was asking it, so it is 140/90, it is 135/85, and I was just in Sevagram like 1 month ago, and Dr. Poonam says that government of India says that it is around 150/100, because the antihypertensive drug are being given like with the one reading or something. So 140/90 is a reasonable thing. Our justosis and the FOXI also says that we have to start antihypertensive for 140/90 millimeter of mercury blood pressure reading, like taken all with all the precaution. These women should be admitted in hospital or the OPD. This is again a very ground level question. So what we see, if the patient is very, very compliant in the follow-up, she can come, she can have self-monitor at the blood pressure at the home. We can do the OPD sort of care and with good self-monitoring and the repeated examination, but hospitalization is appropriate when the woman have the severe feature or the woman is non-compliant. So this is very important, because sometimes we say it is 160/100. We ask the patient to get admitted and they say, what is happening? Everything is fine. So it is our duty that we have to counsel them that anytime it can have, you have to take 4 or 6 reading, come with the your blood pressure recording diary, and you have to come back. So understand them. You have to be flexible, like you can always say that you have to be admitted, and consider they are all socio-economic issues, cultural, familial issue. But important thing is that these women should not be lost with writing a fast prescription of any drug and they are lost and they don't know and they suddenly come with the eclampsia. What we have to do when we are having any daycare, you have to seek the proteinuria, 4-hourly blood pressure, renal function, liver function, and the complete blood count. Other tests like uric acid, LDH, and coagulation studies, Jastosis and FOXY does not recommend for everyone, but in particular circumstances, we have to consider the uric acid and the coagulation studies. Fundoscopy is sometimes required when we want to differentiate between chronic and new onset disease and diagnose papilledema and hemorrhage. So flexibility is the thing, but for all the basic investigations are fine. Fetal evaluation, very, very important, and we have to look first for the IUGR, that is fetal biometry corresponding to the gestational age, amniotic fluid, and the umbilical artery ultrasound. So these are the things which can be done at every resource. Every obstetrician who knows a little bit of ultrasound, good practice, we can do it biometry and umbilical artery ultrasound. But if there is a IUGR, then it is time to do the Doppler very, very closely, and you have to go the umbilical artery as well as the MCA Doppler. So when there is a high resistance or absent or reverse and diastolic flow, this is the time that we have to have all the coordination for expediting delivery. So fetal evaluation is very, very important. When IUGR is a presenting sign of the preeclampsia, we have to be very, very particular for the all Doppler study. And when there is a gross IUGR like less than 33rd percentile and the abnormal Doppler, that it is a significant indicator of the future adverse perinatal outcome. So I will give a very few messages. If umbilical artery absent and the diastolic flow, delivery to be taken no later than the 34th week. And if it is a reverse and diastolic flow, delivery not to be taken later than the 30 weeks. So few important things, and it is like what I say, the umbilical artery Doppler study can be done and can be learned by anyone. After baseline evaluation, you have to look for how to follow. You have given antihypertensive, then you have to follow or platelet count, liver function test, kidney function test, and you have to ask about the ominous symptom of the preeclampsia. So you have to ask actually. Patient is not going to say, because they say our women are so like a compliant, they are so that they don't complain. You have to ask, are you having headache? Are you having difficulty in vision? Are you having right upper quadrant pain? And this is our like very, very important, because when the patient is having amnesia sign, it is more chances that you are not going to continue the pregnancy for a longer time. So tackle the omnius urgently, and we have to act very, very fast for it. So these are the Jastosis which says that how we should ask for the omnius symptom. Additional imaging when we know echo, chest X-ray, MRI, whenever there is a need at the clinical scenario. So it is only not essential for everyone. So this is important that ISHP does not advocate. I will again say that every preeclampsia is to be considered as a very, very important woman to be followed up. How we can have this thing prevent the life-threatening complication? We can have mini peers, that is the clinical assessment like the proteinuria, like the headache, and the full peers with all the investigation what we can have. So I'm emphasizing what solution to challenges, because in every setting we have to give that confidence that you can have follow the mini peers. If the setting is good, we can have full peers, but we have to prevent the life-threatening complication like IUFD or eclampsia or pulmonary edema. So this is a care plan, and the timing of delivery is most important. And what is again, then don't wait for the last wave. We don't want to have the criticality, but a settled pre-eclamptic patient. So seizure prophylaxis and the antihypertensive. So we all know about Maxelf. All the August audience know that it is Maxelf prophylaxis. We don't have to have the magnesium level. Important thing is that we have to make protocol for our institution. So you are afraid, you are single person nursing home, you don't want to give the IV, then you give intramuscular full 10 gram Maxelf. But important thing what Indian Society of Hypertension says, that we must have protocol for our institution to give the Maxalt. This is very, very important. So it is all safety profile of Maxalt is quite okay, and you have to see the urine output, potatal reflex, and the respiratory rate. It is not necessary that you do the magnesium level, and you must have the antidote, that is calcium gluconate, and the assistance like intubation or oxygen when you have any respiratory depression or something with the Maxalt. So important thing that make protocol for every institution, and this is important because this is really lacking in developing country in diverse setting, and this is very, very important. Antihypertensive, we don't want to, the point of start is 140/90. Sometimes few research says 135/85, but of course 140/90 is a general consensus. What antihypertensive we want? Who have the rapid onset of action and short duration of action in event of over-titration. So our aim is to reduce the blood pressure around 15% to 25%. So we don't want the 120/80, it is 15 to 25% reduction. And why antihypertensive? Like around 20 years ago, we say 160/100 is okay because it is compromised. If we give antihypertensive, the fetal compromise will be there. But we know that the hypertensive crisis is the most important cause of mortality that can cause heart failure, myocardial ischemia, renal injury, and the neurological complications. So now we are consensus that we have to prevent the hypertensive crisis, and what we want to achieve, that is around 130/90. These are the drugs which is available to us: labetalol, nifedipine, most commonly used, hydralazine in some like institution, nitroglycerin and nitroprusside, which we give along with the consultation with the physician. So labetalol is with us, alpha methyl dopa we don't have, and the beauty of labetalol is that it is selective alpha beta blocker and it does not compromise the fetal circulation. So this is important, and we are using daily. Maximum dose is 2400 milligram per day, and we have to be very particular, especially with the IV labetalol, that bradycardia is and the congestive cardiac the failure and the heart blocks are the contraindication for the labetalol. Nifedipine never to be given sublingually, it is orally, and a very, very effective drug. It can cause tachycardia and a headache. And this is important because when we give nifedipine, patient suddenly comes back, I am having headache, and we are troubled because it is a ominous sign. So we have to be always counseled that this drug can cause the headache, and when there is a like an intolerance to headache, we have to switch to the labetalol. So these are our drug. Important thing is choose right drug. If the one drug is not effective, use combination of drugs. So going to maximum dose of labetalol, it is better that we give combination of labetalol and the nifedipine. So this is very, very important, and never you have to give the sublingual. So tachycardia again, it causes tachycardia. So the patient is already having 100 or 110 pulse rate, then it is a better choice to give the labetalol to these patients. Not to give antihypertensive, this is very important because sometimes physician prescribe it. So ACE inhibitor, diuretic, before the delivery, angiotensin receptor blocker and beta blocker, except labetalol and osprinolol, are not to be given in pregnancy, and that is very, very important. Eclampsia, the same thing, it is a hypertensive prevention, it is a seizure prevention, but the first thing with eclampsia is the life support, that is airway, breathing, and the circulation. So important. If oxygen saturation is less than 92%, suspect that patient has aspirated or there is a pulmonary edema, because we want to prevent respiratory hypoxia and respiratory acidosis, which is often with the convulsion. So good position, lateral decubitus position, mouth gag in the right, not to put too back so that it can cause the vomiting, good suction, breathing, oxygen, and maintenance of oxygen saturation more than 96%. So the first line care, and with Manyata, Tamil Nadu is very, very active in Manyata. So every nurse must know that what is nursing care is required for these eclamptic women with the eclampsia, and a good fluid, that is the 65 to 85 ml per hour, because what we say, it is a reduced intravascular volume and the patient cannot tolerate the high fluid the aggressive fluid or the overzealous fluid therapy, as of course the catheterization. So good nursing care, and then Maxel and the hypertension, that is that antihypertensive drug. Important thing is that the eclampsia tray should be there. We know as a knowledge, we know everything, but important thing is their availability. It is not getting expired because we have not used Maxel. So eclampsia tray availability, all the things at the one place, that makes the saves the day and saves the mother. So important thing is that these drugs must be available, and always when there is a resistant convulsion, we can give repeat dose of Maxel. But if it is not refractory to it, then the thiopentol, phenytoin. Sometimes we have to give the midazolam to cool down the patient so that we can do the catheterization and IV access. So this is important. And when there is a refractory convulsion, always consider neuroimaging, because patient already might be having cerebral hemorrhage or something. So refractory convulsion, don't go on giving only anticonvulsant. We have to have an overall look on the head imaging and the neurological complication. There can be fetal bradycardia and something, and today there is a normal practice. As soon as patient with severe preeclampsia or eclampsia come, do cesarean. Important thing is stabilization of mother is very, very important. Fetal deceleration bradycardia can be common with the eclampsia, and as soon as mother is resuscitated, the fetal the CTG pattern goes normal. So important thing, never take the patient, unstable eclamptic patient, to operation theater, do all the things which is needed, and then again see what is the Bishop-Viswood, what is the progress of labor, what is CTG, and what is the obstetrical condition, and then take the patient for the delivery. HELP I will not touch, because HELP is now, it can be class 1, 2, class 3. HELP is now considered as a form of severe preeclampsia, and management is the same as in the preeclampsia what we have taken. So HELP has also been redefined by ISHP. We know all the platelet that it can deteriorate in the postnatal period, but it has to be managed like the severe preeclampsia. This message I want to communicate. So ISHP does not recommend HELP management as a separate entity. Cerebrovascular complication is especially important nowadays, because we are using aspirin, we are using a lot of heparin, and the cerebrovascular complication, along with the even 2 or 3 high reading of blood pressure, we can have the neurological complication. So whenever you suspect anything, you have to have the good multidisciplinary approach. Subcapsular hematoma is one of the life-threatening complications. As far as we are considered, we have to look into the elicitation of the ominous sign. Malaise, epigastric pain, upper abdominal pain. If it is there, go for a good upper abdominal scan. And if it is there, it needs a good, very, very good liver surgeon, gastrointestinal, and a very, very high level of the massive transfusion protocol. 108 is with us. We have to have a good transfer protocol. If we don't have that much of setting, and nowadays I don't think that a 1 or 2% nursing home people should have the patient with eclampsia. So give the first dose of Maxel, give first dose of antihypertension. If there is a gestational age less than 34-week, steroid, and transfer with a good protocol. So when to deliver? So in 3 cases, we have to deliver at right time. So if it is preeclampsia, never more than 37 week, absent diastolic flow 34 week, and reverse it is 32 week. So I will be very, very short about it and very clear message. If they develop any of the thing like a progressive low platelet count, progressive liver or the kidney function test, deterioration, pulmonary edema, any abnormal neurological feature, ominous sign, we have to deliver fast, because we don't want any maternal or the fetal criticality. So important thing is that the eclampsia, again, what he say, it is not more than 37 week. And if it is gestational age is less than 24 weeks, it is very early onset preeclampsia, the immediate delivery is the best option, not only for the mother, but also for the baby. Steroid, always a good, like a question mark about it. But if it is less than 34 week gestation, we should give steroid priming. But sometimes the conditions for the mother is deteriorating, then sometimes we can give her one dose and we go ahead with the obstetrical decision. So Maxelf neuroprotection has come. So in this patient, we are giving Maxelf. So that also helps the fetus, and it is a recommended treatment for the neuroprotection for the fetus. Cesarean section for all. This is again a very, very important question, but I will say if it is more remote from the term, more chances for the cesarean section. It is more close to term late onset preeclampsia, and if the patient is already in labor, we can pursue vaginal delivery as good as the 65% number of the cases. However, if it is a severe FGR, compromised Doppler study, any abnormal indication, we have to have a low threshold for cesarean section. So this is important. Do at right time. It should always be a just cesarean section. When you have really issue, we have to have a low threshold for the cesarean section. And in labor, what we want, don't allow the blood pressure to rise. We have to give the H2 receptor antagonist, and we have to switch on to the parental antihypertensive as well as the anticonvulsant sometime. Fluid intake, very, very important, not 60 to 75 ml per hour. This is important. And what is the anesthetic consideration? So again, one message that the regional anesthesia is the safer, except when the platelet count is less than 70. So anesthetic society says around 70,000. If it is less than it, they go for the general anesthesia. Otherwise, the spinal or the epidural anesthesia is safer because there is no peak of hypertension during intubation and extubation, risk of aspiration, and the difficult intubation. Preventing PPH, I have been like in my 20 years journey, I have done so many things about active management of third stage of labor, oxytocin to be kept in fridge. In preeclampsia, it is a very, very important life-saving measure because these women cannot tolerate aggressive fluid protocol and they cannot tolerate the blood loss. So all preventive measure has to be there to prevent the postpartum hemorrhage. Histopathological examination of placenta, because the Indian Newborn Action Plan, like one focus is the prevention of stillbirth. Postpartum, one or two things, never shift these patients before 36 to 72 hours to the normal ward. These patients can have what Madam was saying, that the postpartum eclampsia is the most dangerous, and it is not only eclampsia, we can have a lot of complications like ARDS, sudden hypertensive, flash pulmonary edema. So the market that every nurse and junior doctor follow this rule that this patient with the preeclampsia and postpartum period has to be kept for 36 to 72 hours in the close, the surgical, what we say, the surgical, post-operative surgical ward for the good observation, because the postpartum emergencies are very, very common. We can have ARDS, we can have a postpartum hemorrhage because we are using Maxelf, we are using nifedipine, all are uterine relaxant, and we have to have a very, very close watch for it. All investigation have to be repeated after 2 days and 5 days. You can discharge on day 5. NSID, if kidney function especially is deranged or the platelet function, you have to avoid, and we have to go for the other analgesic. So short-term follow-up, call them after 3 weeks and after 3 months, and check that the blood pressure is normal, proteinuria, their organ functions are there, and if there is a persistent hypertension, we have to refer to the physician. So these women need long-term follow-up. You have to take this opportunity to advise, to advocate them, to make them like a conscious for their health, that you have high blood pressure, you have preeclampsia, you are more prone to have the hypertension in the future, and you have to go for the good lifestyle modification and a regular follow-up with the physician. So life is full cycle, and the pregnancy tests women health status at many fronts. We as obstetricians are fortunate to intervene lifestyle and medical intervention at young age, and what we do in our clinical practice, it is going to affect short and long term of health of women, their family, our community, and our nation. So thanks for always being together. Let us devote time, treasure, and talent for saving mother. So they say the world has become too complex for simple answers. They are wrong. We need simple, dedicated people with clear vision for the top leadership, and I seek everybody's wishes and the vote and support for my Foxy presidential candidature. And once again, hearty thanks for being with the August audience for the TNFOG. Thank you very much.
Thank you, madam. That was a very wonderful talk. You have covered from A to Z, starting from prevention, what is the latest, and up to the all complication management. That was very wonderful to hear too. And we wish you all the very best for your presidential election. And there are two questions in the Q&A and chat box. One question is, mother developing pedal edema and increased maternal weight gain with a normal BP, and LFT and urea creatinine is normal. Urine albumin trace, how to manage them?
These patients, excessive weight gain is the edema. Both these are the women who need close follow-up. What I say that at any moment of time, they can develop and they cannot develop also. But if it is an excessive weight gain and the traces proteinuria, these patients need close follow-up. I will say around 10 to 15 days, we must call her and recheck the blood pressure and recheck the other things. And we have to have a close follow. That is the thing. It's preeclampsia is all about following. And we cannot ignore it actually. Excessive weight gain as well as edema, especially the gross edema, we cannot ignore it because it is low colloid osmotic pressure and many things which are which are cause of it, and anytime patient can have a full-fledged preeclampsia. I think I have answered.
Yeah. Saumita, I think she had understood. And one more question from Dr. Shashikala. Is the risk of postpartum new onset hypertension and eclampsia with a normal BP in the antenatal period has been noticed in patients with a GDM? So the GDM patients, do they develop postpartum new onset hypertension and eclampsia?
What we called it as a de novo hypertension, because patient was not having high blood pressure before, but we have the de novo hypertension. So patient, especially with the obesity, what this question about GDM. So in postpartum period, we have to be very careful. And actually, I shared my one patient, a girl who had the poliomyelitis, and we did cesarean for her, this thing, this orthopedic problem. And she had only one reading of 170/100 in postoperative period, and she had actually cerebral hemorrhage. And after 2 hours, we noticed she was not speaking. Everything was okay. Blood pressure was also not okay, but she had a very bad cerebral hemorrhage, and we have to refer it. So de novo hypertension is the thing, and even sometime occasional high reading can cause really damage. So this is a possibility, of course.
And there is a last question in the chat box. 21 weeks, BP 160/100. How do you decide upon continuation or termination?
Only 160/100 blood pressure, we will not go for the termination. In these patients, maternal organ like all liver function, kidney function, platelet is okay, but more important is the fetal follow-up also, if we are thinking for termination. So only 160/100 is not, I don't think that we will take decision for termination, but overall clinical picture, if it is a oligo, severe oligo, already growth retardation, and the BP is unstable and not responding, then sometimes, but we will say with the ultrasound of the fetal evaluation and the fetal, and it is not a one-time evaluation. That is very important. You have to take like after 15 days, if you are having after 10 days ultrasound, if it is a baby is gaining weight and the liker is okay, then we can continue up to.
But from 21 weeks, I think it will be very tough to bring them up to at minimum 31 weeks. So we have to decide. Okay, madam.
We have to decide, we have to see the response of the patient, how she is responding to antihypertension. So it is not a one-time decision, but you have to take decision like within 15 to 30, 28 days, we know that what we are going to.
There are more than 200 delegates, madam. The now questions are keep coming in. There is one more question, madam. Do we have time?
Yes, this is from Dr. Sampath.
One
Chronic
more
hypertension.
question, Manonmani, we can finish it. One more questions.
So that's why I asked, madam.
Madana, madam, you can answer in the chat box.
Okay, fine.
Okay, madam. Thank you. Thank you for the opportunity to chair this wonderful session. Thank you, ma'am.
Thank you. Yes, now we have 2 questions for the delegates to answer. This questions is not for the faculties. It's only for delegates. Gestational hypertension is defined as a pregnancy with BP more than 140/90 with proteinuria, pregnancy with BP more than 140/90 without proteinuria, increased BP less than 20 weeks, none of the above.
Last 10 seconds. Time.
Sahiti, you post the second question also. After the panel, you can tell the answers. Who is the first one?
Okay, ma'am.
This is
Second
just to
question.
encourage the delegates, Sadhana madam. Other than that, nothing.
Yes.
Second question, ma'am. Please read.
Low dose aspirin prophylaxis to reduce the risk of preeclampsia is from 12 to 14 weeks should be given up to 34 weeks, up to 36 weeks, up to term, up to 38 weeks.
Last 10 seconds. Timer. Okay, ma'am.
Thank you. Sadhana madam, wonderful talk.
Thank you,
As
Dr.
usual.
Sampath. Thank you.
Yes.
Very
Now-
lucid talk, very interesting and informative talk, Sadhana. Nice.
Thank you, Dr. Revati, Dr. Sampath. Your word matters a lot. And thank you, Manumani, for all generous introduction and all the putting questions. Nice questions.
Nice opportunity and thanks for moderating the session. Thank you.
Shall we go to the panel? Can you post the panelist? Panel discussion on PIH. This is already done. You post the panelist. Hey, we have one by one. Shahiti, first you posted Gayatri or someone, no? So now we will go to the panel on PIH. I invite all the panelists. Dr. Tillai Nachiyar. Tillai Nachiyar is a senior assistant in the Tamil Nadu Government Service. She is from the KMC and worked in Omandurar Medical College, KGH, and now she is working in KMC. Presented papers in critical obstetrics and epidural labor analgesia. Field of interest is infertility, laparoscopic surgery, epidural obstetrics, and critical obstetrics. Welcome, Tillai. Next is Dr. Sai Meenakshi. She was a former civil surgeon and former associate professor in Chengalpet Medical College. And she is the vice chairman of Sai Specialty Hospital, Padapai, Krompet, and founder member of Kanjuram Society, and undergraduation from Stanley and university topper in post-graduation. Best Doctor Award, Tamil Nadu Pondicherry 2015, IMA 2019, District Coordinator and DOT for many government programs, participated and chaired session in national and international conferences, national faculty in AHCOG, and she is currently the Honorable Secretary of IMA Tambram, which is a vibrant branch. Welcome, Dr. Sai. Then we have Dr. Vanita Rukmani, Senior Assistant Professor from Theni Medical College, Consultant Obstetrician and Gynecologist in Nadar Hospital, Theni, EC member of TNFOG. She is the Secretary of Theni Society and EC member of the TNFOG, Speaker and Organizing Secretary for many FOXy meetings. Published papers in national and international journals. And her field of interest is infertility, and she has done many adolescent programs. Welcome, Dr. Vanita.
Thank you, ma'am.
Then Dr. Muruga Lakshmi, she is the professor of Coimbatore Medical College, OBGN, and she has done her UG and PG in Madurai Medical College. And a field of interest is high-risk obstetrics. Dr. Muruga Lakshmi, welcome.
Thank you, ma'am.
Whether Dr. Tendral has joined or not, I don't think so. She has joined. Sahiti Tendral pair irka?
No, ma'am.
Okay.
Sujata,
Dr.
ma'am.
Sujata, yes. Dr. Sujata allegation, she is the professor of ONG in Tirunelveli Medical College, Tirunelveli. She is the current president of Tirunelveli OG Society and conducted live obstetrics and gynec workshops and presented many national papers and best paper award in UFOXI, national faculty in AACOG. Welcome, Dr. Sujata, ma'am.
Thank you, madam. Thank you, madam.
Yes, shall we go to the panel? Yes. See, what the panel which we are going to conduct is, it is only practical, no theory. 1 minute. I will share the presentation. Wait, it is not running. Yes. Can you see the?
Yes, ma'am, it's full screen.
Yes, yes, we will go with the, without wasting time. See, now we had so much discussions about the classification, so we will go straight to the case scenarios. Hypertension in pregnancy before 20 weeks and after 20 weeks. Before 20 weeks being chronic hypertension, whiteboard, masked hypertension, essential and secondary. Hypertension after 20 weeks is transient gestational hypertension and preeclampsia. Like that, the classification goes on. So this is the easiest classification, before 20 and after 20, with and without proteinuria. Now proteinuria is not considered, it is considered as end organ damage. Our FOXI guidelines, gestational, chronic hypertension, preeclampsia. Now there is no mild and severe, it is non-severe and severe eclampsia with the change in the lab parameters. So these are all the, again, the preeclampsia is considered as early onset preeclampsia and late onset, that is before 34 weeks and then later 34 weeks. So these are all the latest definition for PIH and eclampsia with seizure. The maternal mortality, why we are concerned about this is hypertensive disorder complicates 8 to 10% of all pregnancy of maternal mortality and preeclampsia of 3 to 9% of pregnancies. See, in the maternal mortality of Tamil Nadu, whenever the audit goes, first thing will be PPH. Even we are talking about anemia and everything, still PPH is the main cause for maternal mortality. And the second is PIH. I think all of us will be knowing. We were seeing the BP, suddenly BP increase, suddenly BP patient through fits. So this word should not be there. We should can prevent it by monitoring. So we will come with the cases. 24 weeks primary with a BP of 150 by 100 comes to OP with no other complications. How are you going to manage? We will start with Dr. Vanita. Dr. Vanita.
Yes, ma'am. Good evening, madam. Thank you for the opportunity, madam. Here we are dealing with the case of primary with BP of 1 record. I would like to ask her to wait for 4 more hours and then to check the repeat BP. If it is still increased, then I will start with antihypertensives, ma'am.
Anyone want to change with this opinion?
Ma'am, here it is 140, 150, 100. The prime
150 by 100. Yes. You can change the name. Doctor, you can change it as your name.
Ma'am, I am Dr. Murugalakshmi.
Yes, ma.
Ma'am, here it is 150 by 100. So we have to go for, as she told, we have to once again record the BP after 4 hours. If it persists, then we may have to admit her, and we may have to investigate and put look for any changes. Like proteinuria, any other liver complications, renal complications, we have to look for and start her and manage.
So, Murugalakshmi, you want to admit this patient is the 24 weeks, 150, 100.
I disagree with that. I will not admit the patient. I am Sai Meenakshi.
Yes, I still, because most of the patient, they may not be billing. I think you can. As
The
you
first recording of 150, 100, I would like to make the patient to wait for some more time. As both the madam said, I would definitely have another recording, both in the sitting and the lying posture with the 4 hours apart, and ask her to come again after good rest, and probably the next day again we can check her blood pressure and go for investigations, look for the parameters, and based on that we can proceed further. It's not necessary to admit the patient and carry on, is my opinion.
Yes, you are correct. Dr. Vanita and Dr. Murugalakshmi is attached to government hospital. You are attached to private hospital.
OP.
We can government hospital OP will be very heavy.
Urinary.
I do. Patient coming on Monday means that's all gone. So your point is also correct. Their point is also we can take into account.
Yes, ma'am. After 1 week, if we asked her to come, we may miss her somewhere else. So it's
No,
better.
next day I would ask her to come, ma'am.
A
Come,
private patient, definitely they will come once they are coming. No, so what is the tablet treatment you are going to start, all of you? Anyone?
Tablet methicillol, 100 milligrams twice a day. And
yes, that is
look for biochemical parameters before starting the tablets.
yes, Sai. That routine investigations you will do and start the labetalol. So it depends on the individual and the follow-up whether to admit the patient or not to admit the patient. As all of us know that the gestational hypertension more than 20 weeks, no fetal growth restriction, good outcomes. BP comes by 3 months after the postpartum, and 25% of women with gestational hypertension will progress to preeclampsia and may have the poorer outcome. So what are all the other antihypertensive anyone want for the sake of the delicates? I think one of you can tell. Tillenachia?
Yes, ma'am. First line and golden drug is labetalol, ma'am. Next line of drug is labetalol, 100 milligram. Initially, we used to start 100 milligram BD, and the second line is nifedipine, ma'am. It's a smooth muscle relaxant calcium channel blockers, and alpha methyl it's a older drug and postural hypotension causes. Nowadays, we are not using that. And labetalol, nifedipine, we are using routinely in antenatal period, and IV, in case of severe hypertension, we can use IV labetalol, and
that we can go it later. You can talk about the oral, then we can go about the.
Okay.
Methyl dopa is the best.
Are you going to talk about alpha methyl dopa?
no, ma'am.
No.
Nowadays.
Not at all using now.
Dr. Sujata allegation.
Madam.
What's your opinion about alpha methyl dopa? Are you giving internal valley?
No, madam. We are not giving. We are not. We start on labetalol, madam, and then we go for nifedipine only.
Yes, as all of us. Anyone?
And increase the dose. If it is
suppose
not
methyl dopa is not available, I think, in the market itself.
We can increase the dose of labetalol and nifedipine if it is not getting control.
It's not available in the market. Today also in our hospital, I saw, I don't know what is happening. Alpha methyl dopa, Sujata, Tillenachar, is it available in the government hospital?
No, madam, it's not available in our OG department.
So it is not the drug of choice as Dr. Sai told. We are going with labetalol or nifedipine depending on the BP. So for the sake of the delegates, I made this slide. Next, we will go to the second case. Gravida 2, para 1, L1 with 32 weeks gestation on antihypertensive since 4 weeks. Complaints of headache and blurring of vision. On examination, per abdomen corresponds to the gestational age. Her BP is 170 by 110. We will start with Dr. Sai Meenakshi.
First, admit the patient.
Until Sai.
32 weeks, severe hypertension, definitely needs counseling. Get an obstetric medicine opinion, get an anesthetic and neonatal team, and counsel the patient. If it is not necessary, also we should get our team in touch and discuss with them and start them with the active intervention, because she's got all the symptoms. Anytime she can throw a fit, she's got all the symptoms.
So she is an early before 34 weeks and she is an early onset preeclampsia. So
Yes.
how are you going to manage, Dr. Vanita?
Since she's complaining of headache and blurring of vision with imminent symptoms, I would call it as a severe preeclampsia. So I will give a Maxel before she is going to throw fits. And since she's not with IUGR, if the BP is well under control, if possible, I can wait for 2 days. I will give a course of steroids for fetal maturity before termination of pregnancy.
So anyway, you want to terminate. Dr. Sujata allegation, what's your opinion?
Madam, I would start her on magnesium sulfate, give her the first dose of maturity dose steroids, and I will bring down the BP and I'll start the termination, madam.
We'll start with termination.
We can,
What are you doing in Coimbatore?
Here again, we admit the patient, antihypertensives and prophylactic magnesium sulfate is given, steroids, and then we start for termination. Either we go for
So it's not prophylactic, it is the treatment. So everyone want to terminate it. That is for the weight of steroid effect, you can wait for 48 hours. So better, why to go for at any time she can go for the complications. So as all of you, you told magnesium sulfate and then termination. For the sake of delicates, Dr. Banita, can you tell the magnesium sulfate dose?
It's the Pritsat's regimen we are following in a hospital, ma'am. Loading dose IV plus AM. Loading dose 4 grams of 20% in dilution. 4 ampules you should take, each ampule containing 2 ml. So totally 8 ml. You take it in a 20 ml syringe, load it with 12 ml of distilled water, normal saline, and then slow IV you should give for 20 minutes. This is called as loading dose. And IM dose is 5 grams in each buttock. That is without dilution, 50%. Every 4 hours, you should give up to a period of 24 hours. And while you give Maxil, you need to monitor patellar reflex and respiratory rate and urine output.
Okay. So delicates, I think you are very clear with the magnesium sulfate dose. See, 2 months back in one of the audit in one place for a BP with such a BP and a hypertension, they have given Epta and Rip. That is the reason I brought this case to the, see, if you attend the audit, there are still magnesium sulfate was not used in some places. See, the TNFOG is having 19 societies. All of you, please tell your members to use this magnesium sulfate. Magnesium sulfate, as all of you told, it is a life-saving drug. Dr. Sai Meenakshi, do you want to tell anything?
I'll follow the same reason. I'll definitely be a private practitioner. I'll involve another senior obstetrician with me.
Okay.
And chart the treatment.
Okay. So pre-eclampsia
and ANC, we are following Sussman's regimen, ma'am.
Yes, you can tell that dose, but since you are in a medical college, you can do, but in the primary health centers and the private, it will be difficult. So I didn't
followed by 4 grams IV dose, followed by 1 gram per hour for 24 hours.
So if you are attached to the medical college, you can go, but it is not approved. You are planning, but still it is not approved. You can go. Because only thing, we cannot stop it. So this is the Pritchard regimen, as Vanita told, 4 gram 20% and 10 gram 50% IM, each ampule 2 ml. That already she has told how the 50% has to be dissolved into 20% with the 20 ml syringe and 10 ml with the 5 grams in the each buttocks, and you are going to monitor maintenance dose every 4th hourly till 24 hours after the last fit or 24 hours after the delivery. So monitoring also, she has told respiratory rate, urinary output and patellar reflex. So how many of you are using this antidote, calcium gluconate, 1 gram, 10 ml of 10% solution? Is there any necessity to use this calcium gluconate?
No, ma'am.
Anita, Tillai?
No, ma'am. We have not at all used, madam.
Yes, definitely it's not used. Murugalakshmi and Sujata?
No, ma'am. We haven't
Madam, we have used once, madam.
Yes,
we already we keep that eclampsia tray ready, madam, in the labor ward. Always
Yes,
it will be ready in the triage also, so that anytime we can need not run for the drugs. So
Yes,
all the 20 ampules.
PIH tray, have you used it?
No, once we have used, madam. Once we have used it.
Sai Meenakshi?
No, I have not used, but I will take my time to counsel the patient and the attenders very necessity with a lot of importance, and tell them of all the complications that can occur because of the elevated blood pressure on the mother, as well as the attending complications on the baby also, and ask for the decision before termination. Because it is very necessary, if it is necessary to refer the patient to a higher institution, then definitely that also has to be taken care of.
He had a respiratory rate was decreased, madam, and the SpO2 was less than 94. We gave a slow IV. We don't know. Definitely, it was due to magnesium toxicity.
Yes,
but we had to give, madam.
All the study also giving the normal dose of Maxil, we have not seen any Maxil toxicity.
We have to confirm with serum magnesium that we are not doing, but there is no wrong in using the calcium gluconate also. Other than that, no problem. If you
We
have,
have to keep it ready.
yes. So this is that case we have discussed. So always I used to tell, whenever a patient after 20 weeks you diagnosis as hypertension, always ask her 4 questions: headache, blurring of vision, upper abdominal pain, urinary output, and the fetal movement. They will never come out of the complaints. We have to put a leading question such that we can prevent the complications. So preeclampsia, as already discussed, it is more than 20 weeks hyperreflexia. This theory is not needed. Proteinuria is a quantitative testing, deduction of protein urine level 300 milligram per 24 hours. Spot protein creatinine ratio is 0.3 milligram. 2 or more consecutive tests is done. This is now the definition is early onset and late onset preeclampsia, that is after 32 weeks. These are all the studies, PREP collaborative network, prediction and complication in early onset preeclampsia. That what we are following in the FOXy gestosis score. Similarly, this is the PREP collaborative network. For the PG, in the exam, they will ask a PRP, what is the PREP, why it is used. It is to identify the early onset and the late onset. More or less, it contains the all gestosis score only. So the PIH tray, as all of you told, these are all the things to be kept ready in the PIH tray. This should be kept in the casualty, this should be kept in the labor ward, and this should be kept even in the operation theatre, everywhere. As per Lakshya, I think all of you are having. Now we will go to the third case. 28 weeks, gravida 2 P1L0 on antihypertension, had fits at home twice. Now admitted with a history of BP with, when you examine 200 by 110, and when you examine the BP, she threw the third fit also. How are you going to manage? First, we will start with Sai Meenakshi. She is the private nursing home owner. Yes,
Severe hypertension. Immediately call the anesthetist, call the emergency team with the obstetric medicine consultant. You have to put the patient in ICU. ICU care is very much essential. Explain all the complications involved for both the mother and the baby, and insist on saving the mother more than the baby because she's only 28 weeks. There's no point in waiting any more time. Termination is the first thing that has to be advocated first.
Sai Meenakshi, only one question. Do you want to continue the treatment in your hospital, or do you want to refer the case to
immediate care has to be given? I will refer the patient immediately to a higher institution. Her BP is definitely not something that can be controlled in a private setup. That too in a medium-sized hospital with a BP of 200, 150, and she's already thrown 3 fits. The maternal morbidity is more here. So definitely the patient needs higher care.
So Sai Meenakshi has referred to KMC. Dr. Tillai Nachiyar, what are you going to do? You are the duty doctor. Patient comes at night, 11 o'clock.
Last duty, I had a same scenario case, madam, on 7th.
Yes, this is very common in government hospital.
Yes, ma'am. It's a 28 weeks and he has no live child, but even though his BP is 200, 110, she throws fit. So we have to save her airway. So left positions and mouth gag, everything should be in a wherever they come with us with the airway, protective airway, and so we have to. She's in respiration. We have to check is she need any intubation or not. We used to alert the anesthetic team, everything. So we have to protect the airway. The line, we have to send the investigations. At 8 weeks, we have to terminate immediately. In case of if it is term, classes the score, but
do you want to give the drugs? No, you didn't tell about the drugs.
Max sulfate.
So the max sulfate has to be given.
We will refer the patient with the prophylactic max sulfate.
Yes, that is needed.
They used to come with the loading dose. They used to given in the primary sector itself. We have to continue the max sulfate dose, and we have to reduce the BP. So I used to give IV labetalol.
Yes.
We have to monitor the BP, and next every 15 minutes once. If BP still persists, we have to give it next to 40 milligram, and then we have to check. We have to control the BP. Should be less than 160 to 110 should come. So once to stabilize the patient, then only we have to go for termination. So early stabilization is very, very important for this eclamptic patients.
What will be the mode of termination, Tillai, in your hospital?
So I used, after the investigations arrived immediately, platelet and hemoglobin and arrange for blood products. I'll go for cesarean section now.
Yes. Dr. Murugalakshmi, do you want
Yes,
to differ from her finding?
Ma'am, here we have to address 4 things, ma'am. One is general management. As per general management, as what she told, we have to save the airway, put her an IV line, catheterize her, then she should be, anesthetist team should be alert. Antihypertensive management is the next one. As she told, labetalol IV should be given, control the BP. The other one is anti-epileptic, magnesium sulfate to be continued. The third thing, termination of pregnancy. Here I would like to go for an hysterotomy since she is around 28 weeks. I would take her to the theater under GA. I will do, and I will continue the elective ventilation till the next for 24 hours. And then I will decide manage.
You tell us LSCS itself, Murugalakshmi, because hysterotomy means what happened now in one time in IOG Institute. Hysterotomy they consider mentioned as hysterectomy. So better now to tell us LSCS in that time. It will be easier to understand. Okay. Dr. Sujata, can you tell the labetalol drip? How are you going to give?
Already she would have been given magnesium sulfate loading dose. So now I have to control the hypertension. We start on IV labetalol, small incremental doses. We have to check the BP every 5 minutes, madam. We have to give every 5 to 10 milligrams slow IV, and every 5 minutes we have to check and slowly double the dose. And if it is not getting control, we can go for a lab up to maximum 220 is the increment, maximum dose. Then we can, it's not getting control, we can think of a labetalol IV infusion. And here we have to monitor the post-ictal state, madam. If suppose post-ictal, she is in a prolonged comatose stage, which indicates a very bad prognosis. She's regaining her consciousness, then we can have a better outcome. So better earlier to terminate. And nowadays, there are a lot of issues. So if possible, if she's in after, now what we do is after delivering also, we immediately take a CT, madam. CT brain, we immediately take.
Yes,
that is
so the same thing. So magnesium sulfate and the labetalol has to be given. Dr. Vanita, if this patient is coming to Theni, will you proceed with the conduct the delivery with Theni, or will you refer to Madurai?
No, ma'am, we are doing it here itself, ma'am, Theni Medical College itself, ma'am.
So that is the main part, because this reference
No
from
reference. Yes, ma'am.
headquarters to medical college, from Dharmaburi to Salem, if it is the situation only, whatever happens, you explain to the patient and better terminate in your place when if there is a anesthetist and ICU facilities are available. Vanita, can you tell that already Sadhana madam has told? Anyway,
Yes,
the complications of hypertensive disorder pregnancies.
Eclampsia, abruption of placenta, DAC, renal failure, HELP syndrome, pulmonary edema.
For baby?
Fetal complications include IUGR preterm, asphyxia during delivery, and the low birth weight IUD.
So as a take-home message, if the BP alone is a problem, no need for admission depending on the position. If needed, you put admission and give the antihypertensive. If it is a pre-eclampsia, please start magnesium sulfate. If it is eclampsia means you can go with IV labetalol. If your hospital don't have facilities and if it is a primary health center, don't delay, give the magnesium sulfate dose and refer the patient. Even in the private hospital, if you don't have facility of ICU care and continuous monitoring of anesthetist, please refer to the college at the earliest. Don't refer the cases at the late stage. That is the message. Recurrent in next pregnancy is 30%.
We are getting a lot of cases now, madam, from the primary health centers. The BP will be 150, 100 or something. And now it is the flu season, no? And the patient will have headache, some cough, and immediately headache, BP. So a lot of cases we are getting referral like that. And we are doing
yes,
all the investigations.
Your area only that Eptoin drip also. Magnesium sulfate was not given and Eptoin is given is in that Tirunelveli area only. So
Yes,
that is
madam.
the reason I thought we should take PIH. Magnesium sulfate is a life-saving drug. Definitely everyone, now we are giving training even for the paramedicals.
Now they are referring very early, madam.
Yes.
140, 100 headache.
Ma'am, here in all private in clinics, any with them, and we always ensure ABC and definitely see to it that the anesthetist intervenes immediately. If it's necessary, we intubate the patient and transfer the patient in a well-equipped ambulance to the nearest government hospital with all facilities. Because Chennai is equipped with a lot of government hospitals everywhere.
Chennai is,
We don't have
only
start
thing
them
that
on
is,
prophylactic Maxel immediately, madam.
yes, that is very, very essential. Always everyone should have minimum of 14 ampules, not 1 or 2. 14 ampules in casualty, 14 ampules in labor ward, and 14 in theatre. So
The
this
box of comes.
So I want to
IV
mention about gestational hypertension, pre-eclampsia and eclampsia. These are all simple cases. 34 weeks primary with upper abdominal pain. Patient was on labetalol 100 milligram since 20 weeks. Per abdomen, it corresponds to the gestational age. Vanita, how are you going to diagnose and investigate this patient?
She's a primary gravida with the 34 weeks of gestation, chronic hypertension because she's
Not
having
chronic. From labetalol started from 20 gestation.
20 weeks. So it's from gestational hypertension, but complaining of upper abdominal pain. This could be of a plain case with the gastritis or with the imminent symptoms. So you always think in terms of an imminent symptom when you deal with a case of gestational hypertension, and you investigate RFT, LFT, ultrasound, and depending upon the parameters.
Yes. So if the patient with upper abdominal pain, even it is a case of gestational hypertension, please investigate everything. Depending on the BP, go with antihypertensive and treat. Consider this case as a help. Liver enzymes elevated and a coagulation profile. Thillai Nachar, how are you going to manage this case?
So this case, we have to see the complete blood count, the hemoglobin and platelet usually low in the HELP syndrome. And LDH is must, ma'am, to categorize the HELP grade 1, grade 2, grade 3. So low platelet and low increase.
No, the platelets is reduced, liver function test is disturbed.
SGOT, SGPT is also increases more than SGOT more than 70 means there is complete help or partial help. If one or two parameters elevated means partial or incomplete help. All 3 parameters increase means it's complete help. So we have to terminate immediately with and bilirubin also we have to check increase bilirubin level. So coagulation profile we have to check with INR and fibrinogen level we should monitor. If fibrinogen level more than 150, so no need for FFP and cryo. Fibrinogen is less than 150, we have to replace the blood products. Platelet is also less than 50,000, we have to replace the platelet and FFP and cryo is must to stabilize the patient.
Transfusion 1:1:1 that can be followed.
Platelet, FFP and cryo we have to improve the platelet and coagulation profile. And once stabilize the patient, we have to terminate primary and we have to terminate this patient with the delivery within 24 hours.
24 hours.
So if Bishop is favorable, we can go for normal. If Bishop is unfavorable, we have to proceed with the cesarean section and we have to remove the placental pathology as early as possible, and then we can stabilize the patient early itself.
Yes, Dr. Thillai. So if the patient, even it is gestational hypertension, complains of upper abdominal pain, please think of help. Do the investigations, and if everything is stable, you can go for normal. And if it is not stabilized, have blood products. Blood products is very, very important for referring the case. Dr. Sujata, do you want to tell anything with this
Madam,
case?
if two important clinically symptoms, if the patient complains of malaise, weakness, always you have to think of hemolytic anemia. So she's going for some help. So we have to, whenever she's having a BP, complaining of some weakness, always think of this hemolysis, one thing. And second thing, also look for clonus. If clonus is present, she's going to throw fits. So those things are now importantly included in all the scoring systems. So we have to look for these features also. Another thing, we look for fibrinogen. It takes a lot of time for us to get the report. So we do a BT, CT, PT and APTT, platelet count, peripheral smear. and then we, if it is a thrombus, platelet is above 50,000, we start the induction. Less than 50,000, we give the correct it and then also start. So we go for termination only.
Why is
Above
it that
80,000, we are.
fibrinogen is taking so much time? Now all medical college, the biochemistry department is
Yes,
well
madam, but
equipped, no?
I think some method, madam.
Okay.
Fibrinogen alone takes some more time. So we.
Ma'am, instead of that, we can go for bedside clotting. Test
Yes, madam, we do CT and
CMT can help
FCT,
you, ma'am.
everything.
Yes.
Bedside coagulation, all this we
Bedside
do. madam.
coagulation, as Dr.
And
Murugalakshmi.
we go for
Clot
the termination.
retraction time is more useful, ma'am. We can go
Yes.
for it.
Nowadays, the PGs, that answer only they will not tell in the exam. So we
Yes,
are doing routinely, but still they will not answer this clot retraction time. So this
Yes,
help is very dangerous and it has to be diagnosed. So when are you going to deliver her? See, patients who are normal. This I think depending on the situation, if it is as you all told, emergency video coagulation platelets means you are going to deliver it. Otherwise, within 24 hours, we have to deliver. Okay, mode of delivery as depending on the Bishop score and the patient is stable, go for vaginal. And if it is not stable and it has to be emergency means you go for LSCS. So these are all this is the last case, I think. Primary para delivered 2 weeks back. Patient had antihypertensive treatment since 32 weeks. And now she is complaints of headache and BP is 160/100. When she came to your Theni Medical College and MRI was done. MRI picture was like this, Dr. Vanita.
Yes, ma'am. Press syndrome, ma'am. Press syndrome, postpartum eclampsia, and get a neurologist.
So how are you going to do? You think that it is very dangerous?
No, ma'am. Only BP monitor, regular BP monitoring
that's
will
all.
be. Yes, ma'am.
So press is nothing to worry. Once if the patient, even in the postnatal period, they can go for all complications. So this posterior reversible encephalopathy syndrome in all medical colleges nowadays the cases are reported. So BP monitoring, again whatever 160/100, control the BP is very, very important. I think this prediction and prevention, no test can predict the development of preeclampsia. First trimester screening can be recommended, but it is very, very cost effectiveness. Risk factors has to be kept in mind. That is the gestosis score. Low dose aspirin 160. What is the dose you are nowadays following? 75 milligram or 150? Dr.
150, madam.
Started at 150, madam. Now starting is initially
150.
Yes, nowadays
Yes,
for
madam.
150 low dose aspirin. This SFLT, PIGF, this is for theory part. Clinically, no one cannot do. It is very, very costly, but in a corporate hospitals, they can do.
PIGF is being done
exercise.
nowadays.
Regular exercise. What side?
PIGF now they are doing.
Okay. So regular exercise is advisable. These are all some prognosis study for the completion state Pelican study, which determines whether it has to be delivered within 14 days. That is triage, PIGF, 5th centile. This study is for recent advance for post-graduation. This gestosis score is for, I think Tamil Nadu government is following this gestosis score now. This is from Foxy. It is very easier. You can allot some house agent to do this gestosis score and see about the complications. That's all. Conclusion is monitor BP properly, follow up the patient, control the hypertension, prevent complications, stabilize and refer the patient early. Once again, I thank our panelists, Sai Meenakshi, Murugalakshmi, Vanita, Dr. Sujata, and Tilai Nachiyar for practical points to the delegates. Thank you.
Thank you, Dr.
Thank you,
Sampath.
thank you.
Thank you.
It was
Thank you so
wonderful
much,
being
ma'am.
with you
Again,
and all the
Dr. Revati, ma'am, for the opportunity, ma'am.
Thank you. Thank you.
Thank you, TNFOG. Thank you for the wonderful
Thank you,
opportunity.
TNFOG, for the opportunity.
Yes. So this
Nice discussion, madam.
PIH is going, increasing. So I thought we will make it as the PIH. Thank you.
Thank you, ma'am.
Thank you, madam. Very
Sadhini,
Thank
can
you.
you post that Sadhana madam is there?
I congratulate TNFOG for such a great initiative starting with young, and what a wonderful questions we are having in question answer box and the chat box, and this is something we always have to read that what will be the correct answer, and that inquisitiveness. Highly salute to all August audience as well, because we are putting with so many questions, and hearty congratulations, wonderful attendance. When people say that webinar, no, people don't log on, but when there is inclusion, and it is something very commendable. So hearty congratulations to all, and all regards to all seniors, and I can say loving regards to Dr. Sampath and Dr. Revati.
Dr. Revati madam,
and Dr.
she is
Priyanam.
giving she is the backbone for everything. She gives permission. We yes, madam. Thank you.
And wonderful. Congratulate young speakers. They were good, and the judges were very meticulous. And I'm going to
permanent judges.
The judges are doing this work for quite some time, more than a year.
Yes, thank you, madam. Thank you. Dr. Sakiti, can you present and that questions first and second? They will get, I think BP apparatus will come to your house. Sahiti? Sahiti is not there, huh? ஒரே நிமிஷம் TNFOG முடிச்சிட்டு. Sahiti is not, but Radhika, give a call to Dr. Sahiti.
Yes, ma'am. Yes, ma'am. Priya here. Tell me, ma'am.
Priya, and the winners போட்டிட்டுனா that we can announce now.
1 second, ma'am.
Ma'am, on the nifedipine magnesium sulfate, the labetalol magnesium sulfate வந்து கொஞ்சம் பேர் அப்பப்போ திருப்பி நால்ஃபாமித்தோட்ரோப்பா தான் எழுதுறாங்க.
ஆமா, சொல்லிட்டே
வந்து யோசிக்கிறாங்க கொடுக்கறதுக்கு. சோ அதெல்லாம் வந்து திருப்பியும் எல்லா இடத்துக்கும் போனா பெட்டரா இருக்கும்னு நினைக்கிறேன்.
ஆமா, எங்க என்ன இவ்வளவு சொல்றோம், திரும்ப போயிட்டு அந்த எப்டாயின் போட்டதுனால I thought we will get.
சிலர்
சாகிதி வரலையா?
Ma'am. Results are, yes, ma'am.
Yes. The first question.
Shall I display, ma'am?
Yes.
Yes.
The first question, the answer, whoever is running first, Dr. Soundarya Jayakumar from Chennai, mobile number 9600518815. So the shield people will give whatever they have decided. I think it may be the BP apparatus or glucometer. Dr. Hemalata for the second questions from Salem. Phone number is Dr. 9994592223. Okay, thank you, Sahiti.
Okay,
these are the winners. You note the phone number. Okay. Now I think today Dr. Vijayalakshmi Gnanashekaran is there for vote of thanks. If she is not there, I will do the vote of thanks itself. So
Yes,
once again,
yes,
I thank our President, Dr. Revati Madam, and the speakers, Dr. Prema, Shyamla, and our Sadhana Gupta Madam, and our judges, Dr. Nidhi Sharma, Dr. Vijayalakshmi, and the wonderful panelists, Dr. Sujata, Dr. Vanita, Dr. Tillai, Dr. Murugalakshmi, and Dr. Sai Meenakshi, and the chairperson, Dr. Manonmani, and our MOC, Dr. Radhika Gauri, for the, I think I have covered every name. Thank you all for being here for the wonderful program. We will meet the next month. Every month, second Friday, we will be conducting this Marathon CME. This month, due to Tamil New Year's Day, we are celebrating 13th. Happy Tamil New Year's Day. Tamil Putthandu
Yes.
Thank you.
அனைவருக்கும் தமிழ் புத்தாண்டு வாழ்த்துக்கள். புது வருடம்